I admit I might be a little bit biased, but to me, dermatology is pretty fun and interesting stuff. So I hope that you can sit back and relax a little bit and enjoy hearing about some dermatological things. So let's go ahead and get started. And I'm going to start out by talking about some common skin disorders. And these are the ones we're going to talk about. So first up, we'll start out with a patient. And the question is, which of the following immunoglobulins is likely to be elevated in this patient? All right, well, everybody remember your answer and keep it in the back of your mind, and we'll come back. So first we'll talk about atopic dermatitis. This is a genetic condition where patients have a very itchy chronic rash in a classic distribution, which is flexural, popliteal, and antecubital fossa, although there are some exceptions to that rule, and I'll go over that in just a minute when we get there. And patients with atopic dermatitis also often have the atopic diathesis, so atopic dermatitis, seasonal allergies, and or asthma, or some combination of those things. You have to have 3 of these things in order to even make a diagnosis of atopic dermatitis. So the exception to the rule in terms of the distribution has to do with infants, and infants can have atopic dermatitis on the face as well as on the extensors, whereas in kids and adults, the typical distribution inside the elbows, backs of the knees in particular. And here you can see a couple of picture examples, an infant with involvement on the face, and then those antecubital fossa, which really are a classic location for it. The basic pathogenesis in atopic dermatitis is sort of an impaired skin barrier. So if you think of that as sort of the basis for all of the problems that go along with it, the impaired skin barrier allows things that belong on the inside, like water, to get out. So patients have very dry skin. And that barrier also allows things that belong on the outside, like irritants and infectious agents, allows them to get in because that skin's just not quite intact. So patients have a diminished irritant threshold, and the majority of them have elevated IgE and IgE reactivity. So they have those Ig molecules that are just floating around waiting for something to sort of stimulate them. And then once this cascade is started, it's really difficult to shut off the whole process. As I mentioned, that impaired skin barrier really leaves patients more susceptible to things like cutaneous infections, and that can be fungal, like dermatophytosis, can be bacterial, and also viral. And again, irritation is triggered by irritants, so common things like wool, for example, on the skin can cause more irritation in an atopic dermatitis patient compared to a normal skinned person. Here again, a classic picture of the involvement of the antecubital fossa and sparing on the trunk in this patient. You can see erythematous, eczematous patches. You can imagine that this may have a little bit of crust right there on the surface, and maybe even some accentuation of the skin markings or lichenification, which is what occurs when patients have been chronically rubbing or scratching the skin. Here's another example, popliteal fossa. You can tell this person's been really busy doing a lot of digging and scratching here, even has some erosions in the affected area. Here's our exception to the rule. So an infant with involvement on the face, no less itchy, and babies can scratch, so they get up there and do some scratching on their face. And then there are a few associated features. So even when a patient comes in, maybe who is completely dressed and you can't see their antecubital or popliteal, there are a few hints that you can get just from looking at their face that they may be an atopic individual. One of those is the creases under the eyes here. So those are called Denny-Morgan folds, or we sometimes call them atopic pleats. And when you see that, that's an indication of atopy. Down here is a patient with ichthyosis vulgaris. So remember I said very dry skin, and this is sort of an example of that ichthyosiform or fish-like scale associated with a very dry skin. And then over here is a patient with pityriasis alba. So these are hypopigmented, asymptomatic patches typically seen on the face, and it's thought that they represent subclinical atopic dermatitis that has resulted here in hypopigmentation, but you never really see that acute eczematous dermatitis in these areas. And this tends to respond just to plain old emollients, and it tends to improve as time goes on. Other associated features include hyperlinear palms, so that's what we're looking at over here. And this is simply more lines on the palms than you would expect in a non-atopic person, hyperlinear. And then on this side is a patient with keratosis pilaris. So these are follicular-based pink spiny papules on the backs of the arms, although another common place to see them is on the thighs and also on the buttocks. Patients a lot of times describe this as feeling kind of like chicken skin or like goosebumps. There are also some variations on the theme when it comes to atopic dermatitis, and one of those is hand dermatitis. So what you're looking at here is an adult with a rash just limited to the palms of the hands, and in adults, hand dermatitis has atopic dermatitis as part of the differential diagnosis. Contact dermatitis is also in there, and also psoriasis can be limited to the palms. But again, instead of that classic flexural distribution, sometimes limited only to the hands in adults. It's not without complications. So the patient here is one with eczema herpeticum, and this is a circumstance where a patient develops an HSV infection, and instead of that being limited to just maybe a cold sore like herpes labialis, they go on to have involvement of all of their skin that has atopic dermatitis, then develops HSV lesions. So patients can get widespread cutaneous herpes simplex viral infection. And then on this side is a similar scenario, except this is with smallpox. So patients develop eczema vaccinatum when they have active smallpox, and they also have atopic dermatitis. So this is a good reason why people who are active military, active duty military and have atopic dermatitis should not get a smallpox vaccine, because they can develop eczema vaccinatum. So the main things in terms of taking care of these patients, the most important thing is maintenance. And the best way to do that is by keeping the skin moisturized. Patients shouldn't stay in the bath or shower for more than 10 minutes at a time on any given day. And you need to stress to them to get a good moisturizer on as soon as they get out of the bath or shower. The things that work best are ointments, which don't have any water in them at all. So plain old petroleum jelly is really very effective. And then the next best thing are creams, as opposed to lotions or oils, which tend not to be as lubricating as creams are. And of course, you want to avoid anything that might potentially be irritating, like fragrances or wool, or even detergents like excessive washing. Aside from maintenance, after that, for acute flare-ups, topical corticosteroids are really a mainstay of treatment. Depending on the location and the severity of the eruption, that's going to help you determine the potency and also the vehicle of the topical corticosteroid to use. Also the age of the patient plays a role in trying to determine that too. And then topical immunomodulators, so that's things like tacrolimus or pimecrolimus, can be a helpful part of treatment, not quite for maintenance, but definitely for disease that is not as severe. So for kind of mild flare-ups, that's when those immunomodulators might play a role. But when patients are in a more severe flare, then a corticosteroid really is going to be your mainstay. And then occasionally we have to use systemic therapy, so systemic immunomodulators, medications like cyclosporin, and other treatments that can be used on the entire skin without being taken internally, like phototherapy. Narrowband UVB is sometimes used, and also PUVA, which is psoralen plus UVA light. So the same information in a different way to look at it. Here at the base of the pyramid is skin care, and irritant avoidance. So that's the moisturizing things, the maintenance stuff that we already talked about. And then the next thing is going to be the topical corticosteroids, and then systemic therapy right there at the top of the pyramid, if necessary. Okay. So here's our question again, and now that we've reviewed the topic, I'll have you vote on this one. Which of these immunoglobulins is likely to be elevated in this patient? Okay. All right, so IgE is the best answer here. Let's move. Next patient, 37-year-old who has not responded to adequate seborrheic dermatitis therapy. What's the next step in management? So looks like you may have to think and remember your answer here, and we'll move on. All right, so we'll come back for the best answer. Seborrheic dermatitis, a chronic, common inflammatory condition where patients experience greasy yellow scale in a typical distribution, which is generally the scalp, the eyebrows and glabella, the nasofacial creases, and we'll look at a diagram in just a minute that emphasizes the sites of involvement. Typically comes and goes and is mostly idiopathic, although we think that the lipophilic yeast called Malassezia furfur plays an important role in its pathogenesis, and that's actually targeted in some of the therapy choices that we use as well. So this affects individuals of all ages, especially common in infants, or it is more common in people who basically have an immune deficiency. So infants fit in that category without a fully developed immune system. Individuals with HIV can present with very severe seborrheic dermatitis. And then for reasons that we don't fully understand, people with neurologic damage, so whether that's a spinal cord injury or Parkinson's disease, any of those things can be associated with more severe seborrheic dermatitis. So here again, the classic distribution. The scalp is the most common place for involvement, but the second most common place is on the face, those eyebrows, the glabella, even the conchal bowls of the ears, and the nasofacial creases. Once it gets beyond that, you have to start thinking about whether something else is going on with this patient. Is this somebody who has a neurologic disease or who has some kind of immune deficiency? But in more severe disease, then we start looking along the sternum, in the axilla, and in the groin as well. So here, a classic example, those erythematous patches with that greasy yellow scale involving this patient's scalp, and kind enough to not have any hair so that we can see the example very, very well. In men, it frequently occurs in the mustache and beard area. So here we're looking at this patient's mustache and beard with underlying erythema and kind of yellow scale that's sitting right on top there. Can be a little bit more subtle. Erythema in general is more difficult to appreciate in darkly pigmented individuals, but here you can see there are some very subtle annular patches in that good distribution along the nasofacial crease in this African American female patient. And then here again, that more severe, more widely distributed, so along the sternum and the axilla. This might be a patient who has Parkinson's or maybe HIV or some underlying disorder. And then here's an infant, and if you can see kind of closely here at the scalp, you can notice that at least there's some erythema and scale there as well. And this patient happens to have some erythema in the diaper area as well as in the skin folds on the arms as well. So in terms of treatment for seborrheic dermatitis, anti-dandruff shampoos, and the top three that are listed here, the zinc pyrithione, selenium sulfide, and ketoconazole, are all available over the counter. Those are common shampoos that can be helpful for treatment, and cyclopirox is a topical antifungal agent that's available just by prescription. The ketoconazole cream applied to the affected area can be helpful for maintenance. But sometimes just to get folks out of the woods, to get rid of that redness that's there in the first place, you really have to get started with a topical corticosteroid. We're talking low potency for use on the face in particular, and also for skin folds. And that's not going to be the best option for long-term maintenance, but just in the short run to kind of get things under control, a topical corticosteroid is going to be helpful. So let's move back to our question here. This patient who hasn't responded to adequate seborrheic dermatitis therapy, what's going to be the next step in management? Okay, great. So check for HIV is the best answer here. Here's our next patient. And the question's going to be, what's the most likely cause of this patient's rash? So get a good look here. I'm going to take a closer look here. And this is a patient with contact dermatitis. So contact dermatitis, I'll let you take a look at that again. We're really looking at erythematous, eczematous patches without that classic distribution like the patient with the atopic dermatitis here, just kind of spread around on the trunk. And some things to pay special attention to are the linear arrangement here, and there's also linear arrangement here. So that's kind of a clue that this is sort of an outside job as opposed to an internal process. So contact dermatitis is an eczematous dermatitis that can either be irritant in nature or it can be allergic. So it's important to know about the differences and when we do testing to try and figure out what the cause is, whether it's allergic or irritant makes a big difference. So when you think about irritant dermatitis, that means that occurs as a result of just having an irritating substance applied to the skin. So if I put a couple of drops of bleach on everybody's skin in here, the majority of us would develop a rash, but it doesn't mean we're allergic to bleach. It just means bleach is an irritating substance. On the other hand, allergic contact dermatitis requires an initial exposure and then a subsequent exposure because this is a delayed type hypersensitivity response. So some sensitization is required, and when it comes to evaluating patients with allergic contact dermatitis, we can do some patch testing to try and figure out what the cause is. So patch testing involves applying a number of different potential allergens, and those can be sort of targeted based on maybe a person's occupation. If they're a mechanic, then you might use different items that they come into contact on a day-to-day basis in a garage versus a hairdresser versus a florist. All of those people may come into contact with different things. And in certain clinics around the country, those substances can be made into special preparations that are then put into these tiny chambers and then applied to the skin and allowed to stay in place, clean and dry for 48 hours. When the patient comes back, the patches are removed and you can look and see what exactly the patient has had a reaction to, if anything. And then another 48 hours after that, the test is examined again, looking for a delayed response there. In the real world of dermatology these days, we don't have time to individually prepare each of those little chambers for each individual patient, and so there's a prepared patch test that looks like this, and it basically looks like a piece of paper tape, and there are 3 different panels altogether. Each one has a dozen small squares in it, and the squares are pre-impregnated with substances that patients may potentially be allergic to. So it's things like fragrances, preservatives, adhesives, things like that. And then the patient comes back, just like we looked at before, has the patches removed, and we look for a reaction. So just to get an idea for common things that patients are allergic to, oleoresin is the allergen that's found in poison ivy and poison oak and poison sumac. But just to realize that not everybody has an allergy to oleoresin. So there is a small population of people who can roll around in poison ivy and not have a problem with it, but the majority of us do have an allergy to it. Nickel is also high on the list of things that people are allergic to, so think about costume jewelry, but other places that you might not think about, like belt buckles and buttons and things, metal buttons on our clothing, can also cause a problem in people who have nickel allergy. Chromium is a substance that's often found along with nickel. In fact, nickel and chromium are used together to make stainless steel. And it's also used in the process that results in tanned leather. So sometimes when people have allergies related to leather things like sandals or watch bands, then chromates are something to think of. And then neomycin. So how many times do you have patients tell you about slathering neomycin all over their whatever, and it just seems to be getting worse instead of better? It may be that they have a contact allergy to neomycin. So pretty common things to watch out for. Here again, allergic contact dermatitis. So we're still talking about eczematous dermatitis here, and this is sort of limited to just where the patient's sandals contact her feet here. What do you think this patient's contact allergen is? Probably nickel. Yeah, so nickel in the earrings, I'm sure that's what everybody said out there, causing a contact dermatitis here just on the earlobes. Still in the contact dermatitis category, but now we're moving from the allergic contact dermatitis to the irritant contact dermatitis. So intertrigo is a form of irritant contact dermatitis occurring just mainly in skin folds where there's friction, maceration, and often moisture right in those skin folds. So groin and under the pannus, sometimes even the axilla and under the breasts are common places to see intertrigo. In terms of treatment for contact dermatitis, again, topical corticosteroids are going to be helpful, but when we are talking about, say, contact dermatitis or allergic contact dermatitis, getting rid of that allergen is going to be the most important thing. And I had plenty of times where patients come in with an allergic contact dermatitis and nickel manifests on the abdomen. And they come in time after time with their metal belt on and their metal buttons that are just sort of making things worse instead of better. So if you don't get rid of that allergen that's in the mix there, then the patients are definitely not going to get any better. Sometimes we have to use systemic corticosteroids. So a patient who's had a really bad run-in with a lot of poison ivy might need a prednisone taper for a time. Here I'll accept one of those dermatology sort of stereotypes. If it's wet, you really should dry it. So patients who have weeping contact dermatitis, acetic acid soaks can be helpful to dry things up, keeping affected areas dry, so airing the skin out. And of course, sometimes people can have secondary infections, particularly candida, to complicate intertrigo, and we'll talk about that a little bit more later. But any secondary infection that's present, you want to get rid of that as well. So here's our patient again. What's the most likely cause of this patient's rash? Okay. So patient with poison ivy, as demonstrated by those linear vesicles that we saw on there. And a few people thought maybe atopic dermatitis. All right, linear places. Here's our next patient. The treatment of choice for this patient's comedonal acne is, so take a look at those options, keep those things in mind, and we'll come back for that question. Talking about oral antibiotics, topical antibiotics, benzoyl peroxide, hydrocortisone, or adapalene. So next we're going to talk about acne vulgaris, extremely common, affecting 85% of adolescents. We really consider it more physiologic than pathologic in adolescents, just because it's so common in that population of people. And for a few unfortunate women, a small percentage, it continues on into their 30s and 40s, and it happens in men as well, but it's a much smaller percentage, maybe about 3 to 5% or so of men that continue to have acne later on. As I mentioned, very, very common in teenagers, but there are other populations where we see a lot of acne as well, and those are, in general, circumstances that result in having excess androgens. So you can see those scenarios that are listed here. When you think about the pathogenesis for acne, I love using this tree as a way to kind of show you the different parts of it. So out there on the branches are those dead skin cells on the surface of the skin, some inflammation playing a role, bacteria playing a role, but really the kind of trunk, the real basis of things has to do with oil production, and then kind of lurking underneath the surface are the genetics and patients' genetic backgrounds. So if we look at those one by one, we know that genetics are responsible for determining the number of oil glands that you have, the number of sebaceous glands, and also their activity. So there's a high concordance in identical twins with acne severity. Oil production is primarily under hormonal stimulation, so in the first 6 months or so of life, infants still have a fair amount of maternal hormones on board, and we can see what's known as neonatal acne in this time frame. Hormone levels go down significantly and remain at a low level during childhood, but then at puberty they shoot up again, and so does the incidence of acne. And then retention hyperkeratosis refers to sort of sticky keratinocytes. So if you think about keratinocytes that normally are shed from the surface of the skin and even shed into a hair follicle lumen, with retention hyperkeratosis, those skin cells just hang around longer than they should. They don't shed away away like they should, and they end up with what's known as a clogged pore. So the medical term, we call it a comedone, which is the primary lesion of acne. The blockage of that follicular infundibulum, or the very top, the opening of the hair follicle, results in that plugging, and then bacteria, oil, keratinocytes all build up in there, and you get larger and more inflammatory acne lesions. So inflammation is certainly an important part in acne because, again, this follicular wall can stretch and then rupture, and that creates a lot of inflammation. And also bacteria like to be in there. They like that sebaceous material. In particular, Propionibacterium acnes, or P. acnes, and also P. granulosum are big players when it comes to acne. And they themselves secrete pro-inflammatory mediators, so they recruit their own set of cytokines to create more inflammation. So you can see how it can be kind of a circular process that just goes on and on. So a few examples of acne. Here, and remember, vulgaris is just common, so common acne here, patient with some erythematous or inflammatory papules, and then also a fair number of those comedones. So remember, when a comedone is open, we call it a blackhead or open comedone. And then sometimes comedones are closed, in which case it looks more like a kind of a flesh-colored papule. So this patient has an inflammatory component with those erythematous papules and also some comedonal acne. Here again, a similar kind of mixed picture. This patient has a few pustules that are present, as well as some of those inflammatory papules, and maybe a closed comedone here, and plenty of open comedones that are all here along that glabella there on this patient's forehead. Acne can involve the face as well as the chest and back. Remember, we're talking about sebaceous, rich areas. So on this patient's chest, quite a bit of inflammatory acne, and maybe even some erosion and crust-topped papules there on the patient's chest. And here again, very active cystic acne on this patient's face, but we still see those primary lesions. We still see the pustules and comedones that are there, especially along the jawline here. And then the patient has quite a bit of edema related to cysts that are underneath the skin. Cystic acne leaves its mark. So this is a patient with a lot of atrophic scarring on the back as a result of having had pretty severe cystic acne. So in terms of treatment, the treatment is really targeted based on the kind of lesions that the patient has. So the best treatment for primarily comedonal acne is retinoid medications, things like tretinoin, and adapalene fits in that category as well. For inflammatory papules and pustules, that's when antibiotics come in, so topical antibiotics, or also benzoyl peroxide, which you can get in a lot of over-the-counter acne medications. And the primary mechanism of action for benzoyl peroxide is as a topical antibiotic. So for the deeper inflamed papules and cysts, that's when you need an antibiotic that's used systemically, and usually using ones from the tetracycline family because they have very good anti-inflammatory capabilities. And then for scarring acne, systemic retinoids are required. And again, those cysts kind of fit down in there. The cysts can lead to the scarring. So when patients have a lot of cysts, then using a systemic retinoid again is going to be important, like isotretinoin. Keep in mind that just about all of these therapies can cause some irritation, and patients need to be aware of that and avoid using things that may potentially cause more irritation. So a lot of times folks think they can just sort of scrub the acne away, and they use the scrubbing beads and nutshells and all sorts of things, but those are definitely to be discouraged because they only make things worse instead of better. So here, back to our patient. Treatment of choice for this patient's comedonal acne is going to be which of these? Okay. So kind of a mixed group, but the majority of you went for the best answer, which is adapalene, which I just mentioned is a topical retinoid. So topical retinoids are going to be the best choice for comedonal acne. The benzoyl peroxide, which a lot of you chose, will be a helpful adjunctive treatment, but if you could only make one choice, the treatment of choice, then the retinoid is going to be a better option. Okay. All right, so here's our next question for thought. Which of these famous people have or had rosacea? Bill Clinton, Princess Diana, W.C. Fields, Renee Zellweger. Okay, so let's talk about acne rosacea now. And here's a patient with a typical case of mild rosacea with some erythema, telangiectasia, a few papules in the central part of the face. And this typically begins in middle age and involves the middle part of the face and people with very fair skin tones. Erythema, edema, papules, and sometimes pustules, which we didn't see in that patient we just looked at, are the classic findings. And I know everybody's thinking that sounds just the same as the acne that we just talked about with the papules and pustules, but the main difference here is with the comedones. So comedones are specific to acne, and we don't see those in rosacea. Another feature that's common in rosacea is flushing of the skin and also sensitivity. A lot of times these patients will describe having stinging or burning of their skin, and they do describe easy flushing, so flushing and blushing. The pathogenesis here is probably multifactorial and involving a number of different things. The flushing is associated with or attributed to vasomotor lability. Fluorinated corticosteroids, which usually are higher potency topical steroids, can induce rosacea on the face. And then Demodex folliculorum, which is a mite on the surface of the skin, is sometimes found to be in greater numbers in patients with rosacea compared to people who don't have it. So here are a couple of examples of a typical or classic rosacea appearance. These are mature adults, not teenagers like you would expect to see with acne. And these folks have erythema and papules and pustules in the central part of the face, as well as some telangiectasia. Rosacea can be divided up into categories based on the main features of the rosacea. So erythematotelangiectatic, the name kind of says it all here. You got redness, you've got telangiectasia, it's erythematotelangiectatic, as opposed to papulopustular, which is primarily papules and pustules. Now, this is not to say that these things don't co-occur. You certainly can have a combination of both of these, but some splitter somewhere decided to separate them up into these different types. You can have ocular rosacea with primarily involvement of the eyes, and then phymatous rosacea is exuberant overgrowth of sebaceous glands in particular, and it can be pretty disfiguring when you think about, is it W.C. Fields with the kind of large bulbous nose? That's rhinophyma or phymatous rosacea, causing that change in shape of the nose. So when it comes to treatment for rosacea, antibiotics are kind of a mainstay. Tetracyclines are used systemically, so again, for their anti-inflammatory effects. And then metronidazole is used primarily topically. And the mechanism there isn't entirely clear, but it's definitely a first-line agent for rosacea. Another thing that's important is avoiding any triggers. And patients will find out for themselves what sorts of things tend to cause triggers in their rosacea. Usually it's things like hot foods or spicy foods. Alcoholic beverages are a common trigger as well. Topical steroids should be avoided because remember I told you that high potency or fluorinated corticosteroids can induce rosacea, so that's something you definitely want to avoid using. And then once you have that disfiguring kind of rhinophyma or phymatous changes, surgical intervention is really the best thing because no amount of topical medication or oral medication is going to make that skin smooth down again or flatten it out. So now that we've talked about rosacea, which of these famous people have or had rosacea? Okay, so all of the above is the best choice here. Okay, so let's move on. We're going to talk about hidradenitis suppurativa next, and this is a chronic scarring disease where patients develop sinuses and nodules, and particularly in the axilla and also in the groin. So think apocrine-bearing skin. It's part of the follicular occlusion triad when we associate hidradenitis suppurativa with nodulocystic acne and also dissecting cellulitis of the scalp. And sometimes people throw pilonidal cysts in there and call it the follicular occlusion tetrad with those 4 things associated with it. Onset usually at puberty, and again, patients initially develop cysts and nodules and sinus tracts in the axilla and groin in particular. For reasons that aren't entirely clear, women tend to be affected more so than men. So here's an example. Patients usually are pretty uncomfortable with this. They have tenderness in those sinus tracts with easily elicited pus often. Treatment is inadequate for hidradenitis suppurativa. Usually these are sterile pustules, but sometimes can become secondarily infected, and so in that circumstance, culture-directed antibiotic therapy can be effective. Isotretinoin, so again, a systemic retinoid, is sometimes helpful, but unfortunately doesn't work great for every patient. And surgery tends to be a last resort, but a very effective one. So often patients have wide excisions of axillary tissue or groin tissue in order to get rid of this process. So we're going to move on here. We're moving on from the sebaceous things and the suppurative things onto some mouth findings. Okay, so when we talk about oral mucosa, there are a number of different conditions that can result in oral mucosal findings. Lichen planus is one of them, and the classic feature with lichen planus is Wickham's stria. So these are reticulate or lace-like white lines on the inside of the cheeks in particular. Usually asymptomatic, but occasionally patients can develop erosions as a part of this, and it's important to look for lichen planus lesions on the patient's skin. Remember, that's the purple polygonal or pruritic papules and plaques, particularly on flexor surfaces like on the wrists. So when you see a patient with lichen planus, look on their buccal mucosa for Wickham's stria. Hyperpigmented gingiva is something to think about in patients with Addison's disease, and you remember these are patients who have diffuse hyperpigmentation because of an elevated melanocyte stimulating hormone, that elevated MSH, and that can be sort of spotted like this in the patient with Addison's disease. Koplik spots are white vesicles on an erythematous base that are a harbinger for measles. So patients usually develop these in addition to fever and malaise, some constitutional symptoms, usually a few days before they develop the rash of measles. And we'll talk about measles a little bit more later on, but if a patient comes in not feeling so well and you see these Koplik spots, you can accurately predict that they're going to develop the rash of measles within a day or two. Hairy leukoplakia or oral hairy leukoplakia looks clinically like white patches on the lateral surfaces of the tongue, and this represents a hyperplasia of the filiform papilla that are there. For that reason, it cannot be rubbed away at all, and you'll see that's an important feature when we talk about candidiasis, because that's an important distinction between those two things. But the hyperplastic filiform papilla usually are asymptomatic, but sometimes people can be disturbed by the appearance of it, and so ablative things like a CO2 laser or podophyllin, which is used for warts, can be effective for getting rid of it, but it frequently recurs, and really no treatment is required. It's caused by Epstein-Barr virus in the setting of HIV. Putz-Jaeger is a genetic syndrome where patients have lentiginous or hyperpigmented macules on the lips and also on the buccal mucosa. And these patients have an increased number of intestinal hamartomas, and they're also at increased risk for cancer of the breast as well as the ovaries and also pancreatic cancer. So seeing a lot of freckles, particularly on the lips and inside the mouth, should be a clue for you to look a little closer and get a good family history looking for these types of cancers. When you think of macroglossia or an increased tongue size, it's important to think about things that might be infiltrating the tongue, and you can see some examples of things that can do that here. In particular, amyloid, acromegaly, so the normal tissue of the tongue getting larger, lymphoma, and hemangioma, and patients with Down syndrome sometimes have macroglossia as well. So here's candidiasis, and remember I told you it's important to distinguish this from oral hairy leukoplakia, because this can look like a white patch on the tongue as well. But when you scrape candidiasis away, you can scrape it away, and what you'll see is some bleeding underneath there, as opposed to the oral hairy leukoplakia that could not be scraped away. This usually requires some kind of upset in the host normal physiology, so in the setting of systemic corticosteroids or antibiotics, and patients can develop oral candidiasis. A geographic tongue is pretty common, about 1 to 3% of the population, so maybe at the next break y'all can look at each other's tongues and see if anybody has a geographic tongue in here. Asymptomatic most of the time, although sometimes people can have a little bit of burning or kind of sensitivity with it. And as opposed to the hyperplastic filiform papilla, now we're talking about atrophy of the filiform papilla. And here is what that looks like. The geographic tongue. And then next up is the strawberry tongue. So the common setting to see this is in the setting of a toxin-mediated erythema, and we'll talk a little bit more about that later on too. But Kawasaki's disease, the exact etiology isn't clear, but remember this requires a constellation of symptoms in order to make the diagnosis, in particular a fever lasting for more than 5 days without some other explainable cause for it. Patients also have conjunctival injection. They can have a variety of different kinds of skin findings that heal with desquamation, and they have this strawberry tongue, which looks just like the name suggests, sort of bright red with prominent papilla there. And then when you think of the bald tongue or an atrophic tongue, the most important thing to think about first is a nutritional deficiency. So we'll cover some of those in just a bit as well. And the other thing to think about is a salivary deficiency. So patients with a dry mouth can have a smooth or bald tongue as well. Sometimes autoimmune diseases like Sjogren's syndrome or other things that infiltrate the salivary glands like lymphoma or mumps or sarcoidosis result in a dry mouth and result in a smooth tongue. So with that, we'll move on from the tongue findings, and this is a patient with black hairy tongue. Let's talk about drug reactions next. There are a few different types that we'll cover, and those are listed here. So here's another patient. The drug which caused this eruption was most likely started within which of these time frames? So think about what your best answer is here, and we'll come back to that. Do you think it's within a few days, a few weeks, a few months, or a few years? So this is a patient with a morbilliform drug eruption. This is a classic appearance for it. Erythematous papules and erythematous macules that sometimes can become confluent. For it to be on the trunk is a common place, and then it moves on from there. So generally starts on the chest and back. And the term morbilliform means measles-like. So here's a patient with measles, and right away you can see why they call this a measles-like or morbilliform drug eruption, because those are pretty similar in appearance here. Another term for a morbilliform drug eruption is dermatitis medicamentosa. And usually it occurs related to a medication that's been started in the last 2 weeks or so of treatment, although that's not a hard and fast rule, and certainly patients can develop allergies or drug eruptions related to medications that they've been on for a much longer time than that, or sometimes a shorter time than that as well. As I mentioned, proximal for starters, so trunk for starters, and then can spread peripherally within a couple of days or so. And patients usually are pretty itchy. That's usually their main concern when they come in with this morbilliform drug eruption. Treatment, of course, you want to get rid of any causative medication, although sometimes that's easier said than done. Certainly, when a patient in the hospital develops a drug eruption and they're on 25 medications, it can be very difficult to pinpoint which one was the problem. Using a timetable to figure out exactly which medication was started when and when it was discontinued can be helpful. And a lot of times the advice we give is, as dermatology consultants in the hospital, is to stop all non-essential medications and kind of go from there. So here again, a morbilliform drug eruption. Other things to think about when you see an eruption like this, a viral exanthem can be indistinguishable, and also collagen vascular disease, so things like lupus or dermatomyositis can sometimes present with kind of a nonspecific morbilliform type of eruption. Medications are common perpetrators for morbilliform drug eruptions, and penicillins definitely are at the top of the list here. But you can see some other medications that are associated as well, and notice a lot of those are antibiotics. So again, when we're called for consultation in the hospital for a drug eruption, we definitely look at the timetable for any antibiotics that the patient is on to see about whether one of those is a likely culprit. In contrast to the morbilliform drug eruption is toxic epidermal necrolysis. So this is full thickness necrosis of the epidermis, and by definition it has to involve more than 30% of the body surface area, as well as having mucous membrane involvement. The vast majority of the time this is related to medications as well, and antibiotics are pretty common perpetrators here, although allopurinol is a common cause, and also NSAIDs. So as often as people take NSAIDs, you would think you might see this even more frequently, but those can be a cause of toxic epidermal necrolysis. These are some other common medications and the reactions that they cause, and I'm not sure there's a way to simplify this necessarily, so it's just something you have to kind of review and keep in mind. Penicillin there at the top of the list and with the biggest box because it can cause probably the most, or can cause a number of different reactions there. Tetracyclines and photosensitivity is something to keep in mind. As I mentioned, tetracyclines used in patients with acne and used in patients with rosacea in particular, so those patients need to be warned of potential photosensitivity. NSAIDs that patients take commonly can have a number of skin findings associated with those as well when they're having an allergic reaction to it. And then the others you can review and look at for yourself there. So now that we've reviewed drug eruptions, the drug which caused this eruption was most likely started in the last what time frame? Okay. Good. So most of you recognize in the last week or two is going to be the most likely time frame for the medication to have been started. Okay, 1 to 2 weeks. Now we're going to talk about inflammatory skin disorders. So here are the ones we're going to cover. Another question for your consideration. This is a patient with similar findings on her knees and elbows. What is the most likely finding on her fingernails? So the choices are longitudinal ridges, horizontal ridges, onychorexis, onycholysis, or onychogryphosis. Think about your answer, and we'll come back to that. So this is a patient with psoriasis, and she's got the typical erythematous patches and plaques with silvery scale right there on the surface. This is pretty common, affecting about 1 to 3% of the population. It can develop at any age, although 75% of patients with psoriasis have their onset before the age of 40, and really the median age of onset is about 28 years old. A small percentage of patients with psoriasis also have psoriatic arthritis, about 7 to 10%, and sometimes you can predict that patients with more severe psoriasis are going to develop that psoriatic arthritis, and there's a small percentage of patients who have psoriatic arthritis that never develop the skin disease. In patients who are immunocompromised, particularly those with HIV, psoriasis tends to be more severe at their initial presentation. Again, the splitters got involved here, talking about different types of psoriasis. So the most common type is chronic plaque type psoriasis, and that's what we were just looking at. That's what you think of with those silvery or erythematous plaques with silvery scale on the knees and elbows in particular. Erythrodermic psoriasis occurs when patients have more than 90% of their body surface area involved with erythematous plaques and patches with scale on there. And this can be precipitated by external factors like sunburn or by internal things like medication. And you might remember that psoriasis exhibits that Kebner phenomenon. So remember, that's when you have damage to the skin in an uninvolved area, and then you develop a patch of psoriasis there. So a patient who has psoriasis and then develops a sunburn on all of their skin may well develop psoriasis on all of the area that was sunburned and then have erythroderma in that way. Pustular psoriasis is more often associated with acute infections, particularly strep infection, and patients can develop large pustules on the skin that coalesce, and sometimes it's described as looking like lakes of pus on the patient's skin, and this is often associated with arthritis. So here again, the classic plaque-type psoriasis, extensor surfaces, erythematous plaques, silvery scale, involvement of the scalp is not uncommon. Involvement of the face would be uncommon, so we don't usually see psoriasis on the face. Other common places to see it, the lumbosacral region, so right there kind of at the lower back and gluteal cleft, and also on the glans penis. And here again, silvery scale. And here's an example of a fingernail affected by psoriasis. So this patient has pits in the nails, which sort of looks like you took a straight pin and poked little dents in the patient's fingernail. And then onycholysis, which is separation of the nail plate from the nail bed underneath there. Psoriatic arthritis can be very mutilating and destructive, and you can see here this patient's definitely got some serious joint damage going on related to their psoriasis. And this is asymmetric, so this is a common presentation for psoriatic arthritis being asymmetric and oligoarthropathy, so a few joints affected here and there. Psoriatic arthritis commonly has nail disease associated with it, and again, like I mentioned, asymmetric oligoarthropathy is a common presentation for it. The DIP joints are affected more so than PIP joints, and sometimes patients can have sacroiliitis, and that's associated with the haplotype HLA-B27. Treatment for psoriatic arthritis is similar to treatment for arthritis of other kinds with NSAIDs, and then sometimes using systemic medications for psoriasis like TNF blockers, methotrexate, and cyclosporin, so systemic immunosuppressing medicines. Remember, you should not use antimalarials for psoriatic arthritis because that can make the skin disease worse. So in terms of treatment for psoriasis, we sometimes look at it as a therapeutic ladder, but now more and more we look at it as sort of a therapeutic continuum. As opposed to starting in one place and moving to the next and to the next, it's better to think about each individual patient and the extent and severity of their disease. So if a patient comes in with, say, 70% of their body surface area involved, you're not going to start with a topical cream just because that's the bottom rung on the ladder. That's somebody who may need systemic treatment. Topical medications can be effective for limited disease and usually have to use pretty high potency corticosteroid medications. Think about trying to penetrate through that thick scale that's there and into that thick plaque that's underneath. Vitamin D derivatives or calcipotriene can be effective as well. The immunomodulators, like we talked about with atopic dermatitis, can be helpful in this setting. Retinoids are sometimes used to kind of try to thin out that thickening or that scale on top there. And then tar is a really old-fashioned medication. It's been around for a long time and has some anti-inflammatory properties, so is effective in that way. This is another setting where phototherapy can be effective, so narrow-band ultraviolet B or NB-UVB, and also PUVA, which is a psoralen plus UVA. can be effective in these patients. And then we use systemic immunosuppressing medicines like you see listed here, in addition to systemic retinoids. And then finally, biologic medications are kind of the newest ones available now, which work directly in the cascade that results in psoriasis. So they work with T-cell interaction one to the next. So here are a couple of different specific biologic agents, and just hot off the presses here, this one, ifalizumab, was taken off the market just last month by the FDA because of an increased incidence of a particular form of leukoencephalopathy, PML, that patients developed when they were taking it. So that one you'll have to cross out on your handout because that's no longer available. Okay, next we're going to talk about lupus. And lupus is Latin for wolf, and it's thought that maybe someone thought that the malar rash of lupus sort of looked like the markings of a wolf, or someone else said that they both sneak up on you and are hard to live with. So not really sure how that name came about, but both of those are kind of true. So I know you probably heard about or will hear about lupus already in your rheumatology section, or read about it in your handout, and you're thinking, why are we going over it again in dermatology? But you'll notice that with the ARA criteria listed here, the first 4 are all related to cutaneous findings. So there's a lot of overlap in dermatology and rheumatology when it comes to lupus. So that photosensitivity rash, the photosensitivity, the malar rash, ulcerations, mucosal ulcerations, and also the discoid eruption can all be all part of the diagnostic criteria for diagnosing lupus. So when we're talking about acute lupus, patients have again, the same things we were just looking at. So here, again, a good example of a malar rash in this patient on your left here. Erythema, maybe a few telangiectasias there as well. And then again, still photo-distributed in the patient on your left there, along the sort of part of the chest, and then on the distal part of the upper arms. Patients have systemic antibodies that are thought to deposit in the skin, and that's what results in the eruption of acute lupus. Discoid lupus, on the other hand, is a form of chronic cutaneous lupus. So this is limited only to the skin, although a small percentage, about 5 to 10% of patients with discoid lupus can go on to develop systemic lupus. Discoid lupus usually is in sun-exposed areas, and what you see clinically are depigmented centers with hyperpigmented or erythematous borders around them. And this can be quite disfiguring and destructive, but again, the majority of the time these patients are systemically healthy and without systemic lupus. Here again, another example, still talking about sun-exposed areas, depigmented center, and then a hyperpigmented edge here along the edge of this discoid lupus lesion. Another distinction to make between discoid lupus and systemic lupus is the type of alopecia that they cause. So discoid lupus causes scarring alopecia, where hair follicles are replaced by a scar, and that's a permanent process, whereas systemic lupus can cause a diffuse alopecia, which is a non-scarring process. So the patient in this picture has discoid lupus, and here you can see pretty widespread with those hypopigmented or depigmented patches, and still preserving some hyperactivity at the edges. And this is kind of an interesting finding here. You can see these sort of polka dots here within this depigmented patch, and those represent pigment cells that are maintained from the hair follicle. So those are places where follicles have been preserved, and the pigment therefore is maintained just in that area. But the places where there has been a lot of activity, where there's that depigmentation, those follicles are gone and they're not coming back. So we'll move now from discoid lupus to scleroderma, another thing that you heard about in rheumatology, but has some good cutaneous findings. Scleroderma can be localized, in which case we call it morphia, and that's seen more commonly in children. usually has a pretty benign course where it ultimately burns out. And that's in contrast to systemic scleroderma, which begins on the face and extremities, but also has internal involvement where patients can have a number of different internal problems, including lung disease and also esophageal dysmotility. And then CREST syndrome, which you remember is an acronym that stands for several different things that we'll review here. So patients with CREST syndrome have calcinosis cutis. They have Raynaud's syndrome, so remember that's the discoloration due to vasospasm in the hands triggered by cold, where they develop white and then blue and then red coloration in the hands. That esophageal dysmotility, sclerodactyly or thickening and tightening of the skin on the fingers, and then telangiectasia can be seen as well. So here's an example of a patient with morphia or localized scleroderma, and almost a little difficult to appreciate here, but what you're looking at is a hypopigmented patch that's here, and if you were able to touch it, it would feel firm and kind of bound down. Here's an example of a patient with scleroderma who happens to be demonstrating some of that sclerodactyly or thickening and tightening of the skin on the fingers. And you can see that this is not a spring chicken, this is a mature adult, and yet he doesn't have any wrinkles on his face at all because that skin is just really tight and kind of bound down there. You can see he might even have some trouble kind of closing his mouth. The lips are very thin. Here's another example of scleroderma affecting a patient's foot. So you can see again still that kind of bound, tight, thickened skin on the toes. And then pay close attention to this sort of speckled appearance on the ankle in terms of the pigmentation, because that's a common feature in patients with scleroderma. And we'll see another example of that in just a minute. Here again, a patient with tight skin. Here you can see she's got some telangiectasia on her forehead. So if you looked closely at those, they just look like tiny dilated blood vessels there. And you can see that kind of tightness around her mouth as well. And then here's another adult with scleroderma. And here's where I was talking about with that kind of salt and pepper discoloration of the skin. You can see across his forehead and also down here around his clavicle. And again, that skin would feel very tight, very firm. This patient might have trouble even moving his head from side to side because of involvement of his neck. Here again, scleroderma with sclerodactyly, tightness. You can imagine this patient's got some definite mobility issues, functionality issues. Going to be tough to use those hands to do much of anything. Here's a patient with Raynaud's phenomenon. So again, this patient's in kind of the bluish stage here. Probably will turn kind of bright red after this, and this happens with exposure to cold. Notice it's not exactly symmetric, and this patient even has involvement of one finger, but the finger right next to it looks totally normal. So in terms of treatment for scleroderma, not a lot. Unfortunately, there really aren't adequate treatments for scleroderma. There's some efficacy in phototherapy, particularly UVA light, because that penetrates deeper than UVB light, but really no fantastic treatment for scleroderma, unfortunately. Let's talk about sarcoidosis next. Sarcoidosis, which I'm sure you'll be hearing more about as the week goes on, because it's a multi-organ system disorder where patients develop non-caseating granulomas, so that's an important thing to keep in mind, in all different organ systems, including the skin. The majority of patients do not have any cutaneous involvement, but about a quarter of patients do. There are some specific findings related to those granulomas or sarcoidosis in the skin, and then there are also some associated features like erythema nodosum. And when patients with sarcoidosis have erythema nodosum, that portends a better prognosis than for patients who don't have it. Typically, the lesions of sarcoidosis in the skin are kind of flesh-colored papules, and we'll see some examples of that in just a minute. And then lupus pernio is sarcoidosis involving the nose and the earlobes in particular. So in order to make a diagnosis of sarcoidosis, you have to have involvement in two different tissues of the body, and that has to be confirmed with a biopsy. So skin biopsy and maybe a bronchoscopy or biopsy from elsewhere in the body to confirm a diagnosis. As I mentioned, any organ system can be involved. You can see the top four there are highlighted for you in pink. Lung involvement certainly at the top of the list, but skin involvement is pretty common as well. Patients can also have involvement in the other systems listed here. And here are some examples. So here we're looking at this sort of pinkish patch. And remember, these granulomas really are within the dermis, so you won't see a lot of change across the surface of the skin where the epidermis is, but what you'll see is changes as a result of that granulomatous inflammation that's a little bit deeper down. So again, kind of an ill-defined erythematous patch here. This patient's got involvement with a sarcoidal nodule there next to the eye. And then here's how it looks on the hand. Again, epidermis looking pretty normal over the surface there, but you can see the erythema shining through from the granuloma that's deeper down there. Remember, sarcoidosis is one of those things that goes under that great imitator or great pretender sort of heading, so it can have a lot of different features clinically. And this is a patient who has sort of more atrophic plaques here with a raised border and some erythema associated with that as well here around the ears. Here's an example on the eyelid. Again, kind of a flesh-colored papule here. It's very likely that this patient has involvement elsewhere on their face, but flesh-colored, and this would feel sort of soft if you could touch it, soft textured papule. Here's an example of a patient with lupus pernio. So remember, I told you that's involvement of the nose and also the earlobes, and these patients are more likely to have upper respiratory or upper airway involvement as well. So still pretty similar to the previous patients, flesh-colored papules, maybe a little bit of erythema underneath there. And then this patient with erythema nodosum. So remember, these are very tender nodules, most frequently located on the shins, like in this patient. Remember, this is a paniculitis, so this is inflammation of the fat that's underneath the skin, so not a lot of surface changes here. And as I mentioned, when patients have erythema nodosum in association with sarcoidosis, they have a very good prognosis, but sarcoidosis is not the only thing that can cause erythema nodosum. And here are some of the other associated findings. So patients with inflammatory bowel disease, those with infections that you see listed here, and also certain medications, including oral contraceptive pills, can be associated with erythema nodosum. So it's important to have that differential in your mind about potential causes for erythema nodosum. In terms of treatment for sarcoidosis, corticosteroids really are a good start and can be used topically sometimes depending on the location and the extent of the disease. Can be very effective used intralesionally because, again, remember those granulomas are in the dermis. They're not right there at the surface, so intralesional corticosteroids can be very effective. And then sometimes systemic steroids are required even over long periods of time, particularly if patients have internal involvement or systemic involvement. Antimalarials like hydroxychloroquine are sometimes used with kind of varying effectiveness for use for skin disease. And then methotrexate is used for sarcoidosis sometimes as well. All right, so here's another question to keep in the back of your mind. What's the most likely diagnosis for this patient with a periorbital heliotropic rash? Okay, so this patient has dermatomyositis. This is an autoimmune disorder where patients have proximal muscle weakness, although you can have dermatomyositis, sine myositis, so having the skin findings without the muscle weakness. when patients do have muscle involvement, a muscle biopsy or EEG or muscle enzymes can be helpful to confirm that involvement. And then they have to have compatible cutaneous disease in order to seal the diagnosis. So the kinds of things we see clinically in patients with dermatomyositis are this so-called heliotrope rash, and the heliotrope is a purple flower, so this looks like a purplish rash around patients' eyes in association with edema, like we can see in this patient. Frequently they have Gottron's papules, which are flat-topped papules located on the dorsal PIP and DIP joints. And also you can see dilated capillaries along their proximal nail folds, and a lot of times the cuticles are kind of ragged. And when you diagnose dermatomyositis in adults, it's important that they have age-appropriate cancer screening, particularly in those first 2 years after diagnosis, because this can be a perineoplastic phenomenon. Dermatomyositis isn't limited just to adults. It can happen in children as well, and as I mentioned, it's much less likely to be perineoplastic in children, but more likely in adults. So here's another example of the heliotrope rash. Remember, kind of purplish around the eyes. And then the Gottron's papules are shown here, kind of flat top papules on the dorsal DIP and PIP joints. And you can also see the cuticles here that are sort of ragged. Okay. In terms of treatment for dermatomyositis, this is another setting where systemic glucocorticoids come into play. Systemic immunosuppressant medications can be used as well, and you can see some that are listed here. And certainly, when dermatomyositis is perineoplastic, then treating the underlying malignancy is important and can result in resolution of their dermatomyositis. So next we're going to talk about vasculitis, and remember the buzzword for that is palpable purpura. This is an example of a patient with vasculitis on their lower legs. So again, if you ran your hands over this would be raised papules with purpura on this patient's ankles and feet. So I know everyone's wondering what could cause vasculitis. Well, anytime you can get an acronym out of a 4-syllable word, then you know that there are a lot of different potential causes here. Keep in mind the kind of overall themes, and common themes here are medications and infectious diseases, so kind of keep those things in mind. Idiopathic fits in, is a pretty common scenario for vasculitis as well, and one of the things that fits into that category is Henoch-Schönlein purpura. So this actually is a patient who has HSP, and this is associated with vasculitis that typically begins on the distal lower part of the legs and ascends. Patients can also have vasculitis of the vasculature to the viscera, particularly that results in abdominal pain or sometimes renal involvement. So it's important to check these patients for renal involvement of vasculitis as well. So here's another question. This is a 55-year-old man with an ulceration of his leg and undermining at the periphery and a violaceous hue. After appropriate testing, no bacteria or fungus was found, and he's in good general health, except for rheumatoid arthritis. So think about what's the most likely diagnosis here, and we'll come back for the answer for that in just a minute. Okay, so here's that patient's ulcer. You can see the examples of his rheumatoid arthritis with his hands there on the sides as well. So this patient has pyoderma gangrenosum. This is an idiopathic ulcerating process with some common associations. So there's inflammatory bowel disease right there at the top of the list again. So if anybody's keeping a running tally, we now have erythema nodosum associated with inflammatory bowel disease. We've got vasculitis associated with it, and now pyoderma gangrenosum. So those folks are kind of set up for a lot of different things. Rheumatoid arthritis patients can have PG, pyoderma gangrenosum, and we see it in multiple myeloma as well. One thing to keep in mind is that a biopsy of this ulcer is not going to be diagnostic. This is almost a diagnosis of exclusion once you've ruled out any infectious causes. And remember, in the question I just gave you, the patient had bacterial and fungal testing, which was all negative. And that's the standard, is for cultures to be negative, although sometimes it can become secondarily infected. But again, the biopsy here is not going to be diagnostic. What you have to look for is classic features of the ulcer, and we'll go over some of those in just a second. And also look out for those negative cultures, and look in the patient's past medical history for any of those associated conditions like inflammatory bowel disease. So here's an example of pyoderma gangrenosum, another example. And this patient has kind of a cribriform, or that sort of lace-like ulceration here. And these are exquisitely tender. You probably can imagine that just from looking. Classic features here include that cribriform finding on the surface, but over here is what you're looking at with that sort of violaceous, undermined border. And here's another example, just kind of a run-of-the-mill ulcer, but then when you look at the border, it's sort of undermined and kind of got a bluish or bluish-purple color to it. In terms of treatment here, certainly any secondary bacterial infection you want to get rid of, and then glucocorticoids or sometimes other immunosuppressing medications really are the standard. If patients will allow you, they tend to do pretty well with even intralesional corticosteroids, but you can imagine it's hard to convince somebody with a big painful ulcer like that you want to stick a needle right in there. So systemic steroids tend to be a better choice. So I hope everybody remembers this patient with similar findings on her knees and elbows, and what do you think is going to be her most common finding on her fingernails? Okay, good. So everybody knows that onycholysis, which is separation of the nail plate from the nail bed, and also pits in the nails, which is that tiny dents in the nail plate, are what you see in patients with psoriasis. Here's our other patient. What's her most likely diagnosis considering her heliotrope rash? Okay, good. So she has dermatomyositis. And then here's our man with the ulceration on the leg and the negative cultures. What's his diagnosis? Okay, good. So nobody thinks that he sits around with his rheumatoid arthritis hands and picks a factitious ulcer in his legs. Good, good. All right. Now we're going to talk about vitamin deficiencies. So first up is B12. This can cause deficiency here, causes diffuse hyperpigmentation, megaloblastic anemia, and these patients can have neuropathy and also psychosis. And then remember, B12 and folate go together, so a lot of the findings of deficiency of one are similar to the other. So patients with folate deficiency also have diffuse hyperpigmentation and megaloblastic anemia, but we know that folate deficiency is associated with fetal neural tube abnormalities when it's deficient in pregnant women, so folic acid supplementation is important there. And another feature of folate deficiency is the bald tongue. So remember, we talked before about the smooth or bald tongue in association with vitamin deficiencies and also with xerostomia. So here's one of those specific examples. Niacin deficiency results in pellagra. So remember, that's the 3 Ds, that dermatitis, which can be nonspecific, but more often is a photodistributed, very tender eruption. I'll show you an example of that. Here you can see it's very sharply demarcated around the patient's neck, so you can almost imagine what his shirt looked like that he had on, because you can see exactly where the sun hit him. These patients can have a bald tongue as well, and then that diffuse hyperpigmentation is a feature here as well. Zinc deficiency can be congenital, where patients have a defect in zinc uptake, or it can be acquired. In both settings, the clinical appearance is similar with erythematous patches that are primarily periorificial, so around the mouth and also in the anogenital area, and they usually resolve pretty quickly with zinc supplementation. In the congenital setting, we call it acrodermatitis enteropathica, and sometimes that term is used to describe acquired zinc deficiency as well. And then vitamin C deficiency, you're all familiar with as causing scurvy. So patients develop perifollicular hemorrhage, and they can have a lot of ecchymoses or bruising. They also have loose teeth, and this can affect the gingiva as well. So they have a lot of swelling of the gingiva, and sometimes can have bleeding here, and also can lose teeth sometimes. So that's nutritional deficiencies, and now we're going to move on to skin infections. So here's our question for consideration. 42-year-old construction worker who comes in with an asymptomatic groin rash, which he self-treated with neomycin, polymyxin, bacitracin, and OTC terbinafine cream. So he used some of everything in his medicine box, and he didn't have any improvement. With the Woods light examination, he got bright red fluorescence. So what's his diagnosis? So those are your choices here. Think about it. We'll come back to that. So these are the skin infections that we're going to talk about. And first up is erythrasma. So this is a patient with erythrasma affecting the groin. This patient has tan or hyperpigmented patches along the inguinal creases and also involving the scrotum. And when you shine a Woods light on there, what you see is this coral red or bright red fluorescence. And that's diagnostic for erythrasma. So again, patients have sharply demarcated brown scaly patches, usually in the groin, but can involve the axilla as well. And this is caused by the bacteria Corynebacterium minutissimum. Again, that Woods light examination with the coral red or bright red color is diagnostic, and that's because the bacteria itself has porphyrins that fluoresce when exposed to the Woods light. Best treatment for it is topical antibiotics, particularly erythromycin, or you can use clindamycin. And for people who are not so sure and treat it as a fungal infection, sometimes you can get lucky because it does respond to some topical antifungal agents that you see listed here. So again, a bacterial infection, treatment of choice here is topical erythromycin, but does respond to antifungal agents as well. Impetigo is pretty common superficial skin infection caused by Staph aureus the vast majority of the time, although sometimes it can be caused by strep as well. And the staph produces a toxin that attacks the desmosomes that hold the keratinocytes together in the case of bullous impetigo. So once those desmosomes are damaged or destroyed, what you get is a separation within the epidermis, and that's what you're looking at. And the histopathology here is just a superficial separation in the epidermis, which accounts for bullous impetigo. What you see are thin-roofed vesicles, and often they are already ruptured by the time the patient gets seen, and that's when they get that sort of honey-colored crust is one of the buzzwords or classic things used to describe the appearance of impetigo. Usually asymptomatic. Here are a couple of examples. You see it pretty frequently in children, particularly around orifices like around the nose. And here you can see kind of that honey-colored crust there that's described, and here certainly on the patient's lip. And here's another example. Very classic appearance for impetigo here around the patient's mouth. Superficial erosions. Remember, we looked at how it looks under the microscope, so very superficial within the epidermis, a separation there, which causes this kind of crusty appearance. This is self-limited, so sometimes if patients wait long enough to go see someone about it, it will resolve on its own. But by the time they come in to see you, the best treatment is generally going to be a topical antibacterial agent like mupirocin, which works well, particularly against staph and MRSA, or sometimes patients require systemic antibiotics, and that can be done as well. Eczema is sort of similar to impetigo, but this is a deeper infection. So this causes shallow ulcerations that have a very thick crust right on the surface, common to see on the distal part of the lower legs like we're looking at in this patient, and classically described as having this really thick sort of shell-like crust on the surface here. So here again a closer appearance of eczema with a superficial ulceration and a thick crust, and this really does look kind of like a seashell right there on the surface there. Erysipelas is caused by group A strep, and this is a superficial cellulitis that particularly involves the lymphatic. So patients experience a lot of edema, as you would expect with lymphatic involvement, and it typically is sharply demarcated, and the face is a common area to see it. So here's an example of a patient with erysipelas, and you can see it proceeds on to a point, and then it just stops right there. So very sharply demarcated, a lot of edema and erythema here as well. And then necrotizing fasciitis. So this is a gangrene that's caused by streptococcus. And initially patients have a break in the skin or some kind of site of entry. They subsequently develop a cellulitis there, and then they develop a rapidly progressing necrosis at that area. So this made it into the tabloid press at one point, flesh-eating virus, so not quite the best terminology there, invading the U.S., and no American is safe, and pretty scary stuff there, but when I show you a few pictures of it, you might agree. So here's a patient with necrotizing fasciitis, and you can see kind of a pale and erythematous appearance, that sort of bluish pallor. So this is a patient who definitely has some underlying necrosis here and probably will go on to develop necrosis of all of this area on the buttocks. Here's an example of a patient with necrotizing fasciitis on the toe, and you can imagine maybe some maceration or a break in the skin between the toes, creating that portal of entry, and then the cellulitis and fasciitis. Here again, you can appreciate probably some necrosis going on here at the periphery, and certainly in the center with some ulceration going on there. And then after debridement, a lot of bad tissue has to be removed. So here you can see we're looking at patients' muscles and tendons underneath there after a very, very extensive debridement because of the extent of the necrosis that was there. Here again, very extensive debridement afterwards, muscles and tendons that are all evident there, and a surgical repair after one of those extensive surgeries. So now we'll talk about scarlet fever. And so we moved from directly bacterial things again into toxin-mediated things. So scarlet fever is mediated by the toxin produced by group A strep. So patients may start out with strep throat, like a strep pharyngitis or tonsillitis or other kind of strep infection. And then the toxin produced by the strep in that area goes on to cause scarlet fever. And patients develop kind of a sandpaper type of a rash. So the skin usually is normal in color and may have a little bit of erythema, and then has a rough feeling to it, just like sandpaper. Sometimes people can have accentuation within the skin folds, so they develop petechiae sometimes within the skin folds, and we'll see an example of that as well. Remember the strawberry tongue that we talked about with mucosal lesions? So I told you then that it's often toxin mediated, and scarlet fever was mentioned there. So here again it's coming back to us. And then as the scarlet fever eruption resolves, patients develop desquamation. So here again is the strawberry tongue. Down here we're looking at the desquamation as the eruption resolves. And then this is some accentuation within the skin folds, and those are actually tiny petechia. We call it Pastia's lines right in the skin folds there in a patient with scarlet fever. So I'll leave the details of discussion for your infectious disease section, but suffice it to say, penicillin V is a good choice. Staph scalded skin is also toxin mediated, but it's mediated by the exfoliative toxins A and B of the staph organism, and usually this does not have a cutaneous source. Remember we talked about maybe breaks in the skin and having skin infections, but here it's usually more like sinusitis or otitis, and this causes that same intraepidermal skin split that we were looking at with the bullous impetigo. So you can sort of think of this as a diffuse or generalized bullous impetigo, because you get that very superficial break in the skin because the toxin has an effect or attacks the desmosomes that hold those keratinocytes together. So widespread peeling of the skin, but the skin underneath is still epidermis, so this doesn't have any scars when it heals, and patients usually resolve pretty quickly within a few days. Toxic shock syndrome is more serious than the other things we've talked about so far. So it's got shock right there in the name, and certain patients can develop or can go into shock as a result of this, mediated by this toxic shock syndrome toxin, say that 3 times fast, from Staph aureus. Patients can have abrupt onset of hypotension and fever and organ failure, and this made the press a lot maybe in the early or mid-1980s or so, related to some particularly some tampons that were advertised as being highly absorbent, and they had a high amount of polyester in there. They're no longer available, but it wasn't clear whether they were a good home for the Staph aureus to be, or whether they might have been somehow tainted. So toxic shock syndrome can be fatal, and this is a lot more serious than the other things we've talked about, but some similar features with desquamation of the palms, and here you can see a patient with conjunctival injection as part of the syndrome. Next is abscesses and furuncles. Here's a big abscess, erythematous, warm, tender nodule that's here. In the strictest definition, there's a separation between an abscess and a furuncle. An abscess is a collection of pus that's within the dermis that doesn't have any wall around it in particular or any boundaries, whereas a furuncle originates from a hair follicle, and that's the difference one to the other. Most frequently, both are caused by Staph aureus, and when we see a collection of furuncles, we call it a carbuncle. So I'll show you an example of that too. So here are some furuncles on a patient's buttocks, and follicular-based here, erythematous, tender nodules. Some here looks like might be sort of draining some already. And here's a carbuncle, so a collection of furuncles that are close together, and here again you can see filled to the brim here, about ready to erupt. And here a furuncle that already is got some pus coming from it here. Tender erythematous. And here again can definitely be multiple, so a patient with multiple furuncles or carbuncles here with a lot of purulent drainage already. The treatment here is to incise and drain, so to open it and empty it out, and patients will have a lot of relief once you do that. The other things listed here are important too, so culture of any material that's there and appropriate antibiotic therapy as directed by the culture, and then warm compresses are part of the treatment as well. But again, the most important thing is to just get in there and empty that out. Now, talking a little bit more superficial here, folliculitis is an infection just of the upper portion of the infundibulum of the hair follicle. When we talk about inflammation of the entire hair follicle, then that's called psychosis. But just talking about the superficial part here with folliculitis. So folliculitis can be caused by a number of different organisms. It can be bacterial or viral or fungal, and also can be exacerbated by external factors like occlusion or irritation. So here's an example of a patient with a staphylococcal folliculitis, and these are follicular-based erythematous pustules. Here again, a close-up view, and if you look close, you can see a hair that's right in the center of that pustule, that's right in the center of the screen there. So it has to be follicular-based in order to call it a folliculitis. Here's an example of a patient who was using a corticosteroid under occlusion for a rash on the distal lower leg and then developed a folliculitis there, but similar findings, follicular-based pustules with some background erythema that's present as well. Now, in gonococcemia, patients have pustules as well, but they are associated with petechiae. And they are few in numbers, maybe not more than a dozen or so on any one patient. So pustular petechiae is kind of a key thing to think of when you think about gonococcemia. Remember I said maybe about 12 or so on a patient. If you do a culture from one of these pustules, it's generally negative, but if you go to the source, a genital culture, that will be positive for gonorrhea. And patients usually can be pretty sick by the time they have disseminated gonorrhea, so they might have fever or arthralgia or arthritis. Here again, this is a pustule, but also associated with petechiae in the background there. And here again, a pustule, sort of a hemorrhagic pustule here with some petechiae in the background. And here again, few in numbers, and it's no coincidence that I'm showing you a lot of acral surfaces because that's a common place to see it on the hands here. And then if you go to the source, you will get a positive culture there. So gonorrhea treatment, I'm sure you'll review in detail in your infectious disease section. Keep in mind it's important to cover for chlamydia as well. Meningococcemia is caused by Neisseria meningitidis as opposed to the Neisseria that causes gonorrhea. Patients can be very, very sick with this. Fever, hypotension, purpura, DIC, and this is something that occurs more frequently in patients with complement deficiencies, so that's something to think about and to look for if a patient presents with meningococcemia. Again, serious illness with a 10% mortality rate, and that's whether treatment occurs promptly or not. So even with prompt treatment, pretty significant mortality rate. Pseudomonas is a ubiquitous bacteria that is opportunistic, so it likes to have the door sort of opened up for it. And I'll show you some examples when we get to that. This is another one that produces a fluorescent pigment similar to the Corynebacterium that we looked at causing erythrasma. So Pseudomonas can cause folliculitis, in particular hot tub folliculitis. So in this setting, the Pseudomonas waits for the skin to be superhydrated underneath the bathing suit in order for it to kind of go in and cause a problem. And patients usually develop itchy erythematous papules and pustules only underneath where their bathing suit was located. So again, that superhydration from the bathing suit gives the Pseudomonas kind of an open door to get in there. Now, this is a self-limited process, so without any treatment it will ultimately resolve, but if patients come in requiring treatment, then acetic acid soaks can be effective, and just as kind of a point of reference, vinegar that you purchase at the store usually has about a 4 to 8% acetic acid concentration, so 5% acetic acid it's reasonable to use regular vinegar that you purchase at the store. Pseudomonas can also cause cellulitis, and this is usually a secondary infection. So as I said, not usually an initial perpetrator. It likes to have the door opened by something else. So Pseudomonas can occur as a secondary infection in cellulitis, and sometimes patients can develop septicemia, and when we get to ecthyma gangrenosum, you'll see what some of the sequelae from septicemia with Pseudomonas can be. The cellulitis is usually pretty tender and dusky with that purulent material and fruity odor that's associated with Pseudomonas in particular. And again, those acetic acid soaks and ciprofloxacin are good treatments for it. So ecthyma gangrenosum occurs in the setting of immunocompromised patients who have Pseudomonas sepsis, although not all patients with Pseudomonas septicemia will develop ecthyma gangrenosum. Patients usually start out with kind of a purpuric macule, and then that can get larger. They can develop a hemorrhagic bulla and ultimately develop cutaneous necrosis. Here's an example of what that looks like, and certainly appropriate antibiotic therapy is required in this setting. All right, so this is back to our construction worker patient from before, remember, who used everything in the medicine cabinet for his groin rash. So here's your chance to vote. What do you think this patient's diagnosis is? All right. So erythrasma was the best choice because remember he had the red Woods light examination diagnostic for erythrasma. Here's our next question for consideration. 26-year-old man who comes into the emergency room after a bite from his girlfriend's cat. What is the treatment of choice for this guy? I think I heard something about a treatment for the cat, but we're looking for treatment for the patient. All right, so just a word on animal bites. Dogs and cats, most frequently, Pasteurella is going to be the organism that's there, as opposed to humans, which have all manner of bacteria, polymicrobial there. Treatment of choice is going to be certainly lavage, rinsing things out as best you can, and then amoxicillin. And then our patient who we just talked about with the cat bite, the treatment of choice for him. Okay, good. So let's move on. This is our 28-year-old school teacher who comes in with a scaly patch of alopecia, and a culture confirms tinea capitis. So what's going to be the treatment of choice for this patient? So this is for your consideration. Looking at the options there. And keep in mind what you think the best choice is. So let's move on. We're going to talk about fungal infections next, and here you can see a large patch of tinea corporis here, making that typical round shape. That's why it's sometimes known as ringworm or tinea. And this is a superficial fungal infection involving one of three specific genera of fungus. If it doesn't involve one of those three, which are trichophyton, epidermophyton, and microsporum, which are not all that important, but it is important to know that those specific fungi cause dermatophytosis, and nothing else should be called tinea unless it's caused by one of those organisms. So that'll come up again in just a bit. Dermatophytes are pretty effective organisms at what they do. They can get into the keratin on the surface of the skin, as well as hard keratins like into nails and into the hair shaft. And the way that we call a dermatophyte infection is with the first word tinea, and that's followed by the Latin term for the anatomic site that's involved. So tinea capitis on the head, faciae or tinea barbae is specific for the beard area on the face, tinea cruris in the groin, manuum, or sometimes we say manus, involving the hands, and pedis, involving the feet. Tinea corporis is kind of a catch-all for some place on the body that's not specifically named by one of the other terms. And then tinea unguium or onychomycosis is the term for nail involvement. So here's a patient with their groin involved. So the term here for this patient would be tinea cruris. Here's a patient with hand involvement. So this is tinea manum. or Manius. And one of the things to note here is a specific accentuation within the creases of the palm. So remember I told you that atopic dermatitis is part of the differential for hand dermatitis in adults, also psoriasis and contact dermatitis. And dermatophytosis is something to think about as well, especially if you see accentuation like this along the creases in the palms. Here's an example of tinea pedis. And again, erythematous patches with scale here, particularly along the toe webs. And if you looked in between this patient's toes, you would see even more of the same, as well as some maceration probably in there as well. Here's another example of tinea pedis, but this is an inflammatory variant. So this patient has vesicular tinea pedis, and what we're looking at are vesicles here along the sole of the foot. And here you can see he's got a big tinea-infected toenail there as well. So that helps to point you in the right direction. If someone came in with these vesicles here, you may not think of a dermatophyte infection first, but looking at that toenail is going to help kind of steer you in that direction. Here again is another example of a vesicular tinea. This is just on a patient's arm, so this counts as tinea corporis. You can see that that round shape is still maintained. This patient happens to have some scale in the periphery, which is a red herring from the Band-Aid she was using, so don't look at that. But what you're looking at are the vesicles that are here, and you can see some of them have ruptured, so there's some fluid there as well. But if you looked at the blister roof, you would be able to see that dermatophyte organism. So we'll talk about that in just a second. Here, tinea of the nails was tinea unguium, right, or onychomycosis. And here you can see the nail plate that's thickened, and here was so brittle that a lot of it just sort of broke away and has kind of chipped away. Tinea capitis on this patient's scalp, and even here the round shape is maintained. Remember I told you that the dermatophyte can get inside the hair shaft, and that's exactly what's happened here. So the hair shafts break at the surface of the scalp, and what you see is a patch of alopecia, and sometimes you can appreciate a little bit of kind of stubble because those hairs are broken right at the surface of the scalp there. Tinea capitis, another example of tinea capitis, but this is again a more inflammatory tinea capitis. So this patient has a big round patch of alopecia, but they also have it studded with these pustules and vesicles here, and this is called a carrion, very inflammatory. So to make the diagnosis of dermatophyte infection, you do a KOH preparation, KOH standing for potassium hydroxide. You can get a scraping from the surface of the patient's skin, or in the case of the vesicles, you can take the roof of one of those vesicles, put it on a slide, put a cover slip over it, and put a drop of KOH. There are a number of different ways to do it, but my favorite way is to put a drop right next to the cover slip so you get kind of that capillary action and the solution spreads across your sample underneath there. You can heat it up to sort of speed up the processing, or if you have time, you can put it aside for a bit and then look at it under the microscope. And in ideal circumstances, what you would see are these filamentous hyphae. So these tiny, thin hyphae that are branching. And if you want to make a diagnosis of tinea capitis, you have to do a culture there because you may not be able to get a positive KOH from any part of the patient's scalp. So DTM, sometimes they say it stands for dermatophyte test media, although the person who discovered its initials are DT, so sometimes it's called David Taplin's media as well. But it's a specific medium for dermatophyte, and it starts out looking kind of a golden brownish color, and the pH changes as a result of the dermatophyte growth into this red color. So what you're looking at here is the fungal growth here on the surface, and then this is a red color change of the media. So that's a positive culture there. In terms of treatment, there are a lot of different choices for topical medications. You can use imidazoles, triazoles, polyenes, and allylamines. And again, another dermatology adage to make wet things dry, so you want to make sure the area stays as dry as possible. We do sometimes use systemic antifungal medications as well, and that really just depends on the extent of the person's disease. So if it's going to be an area that's too large, or a patient that you don't think is going to make the effort to rub a topical medication on the entire involved area, then that's when you would think about a systemic treatment. And the other time you think about it is with tinea capitis. So systemic medication is required in order to adequately treat tinea capitis, and the treatment of choice is griseofulvin, used in kids and adults, and usually an 8-week course is required. You can see terbinafine and itraconazole listed here too, because those are acceptable treatments, but not the first line. Topical things can be used as adjunctive therapy in tinea capitis, so things like selenium sulfide, or remember cyclopirox from way back with the seborrheic dermatitis can be used. And usually patients shampoo their hair with one of these, leaving the lather on for at least 5 minutes before rinsing it a few times per week, in addition to the systemic treatment. The other thing is it's important that people who have it are not getting repeatedly exposed. So often you'll see several, you may not see as internists, doctors for adults, but what you can see are several members of the same family, we'll say, as opposed to the kids, who pass the infection around one to the next. And so it's important that everybody gets tested who may have some signs or symptoms with scaly or patches of alopecia on the scalp, and everyone gets treated because it's pretty easy to pass around. This is candidiasis, so from one fungus to a yeast here. Candidiasis, so the skin is caused by Candida albicans and also sometimes other Candida species. This one is sort of like Pseudomonas in that it likes to have the door opened for it. So candidiasis waits for skin that's sort of macerated or occluded in order to have its effect. It doesn't do very well at all with the hard keratins, so you would not get a Candida type of scalp infection or hair infection like tinea capitis, but Candida can sometimes make its way into nails, so you'll occasionally see a Candida nail infection. Here's an example of candidiasis in an infant, and again this skin is already macerated from being in the diaper area, and then candidiasis is allowed to sort of secondarily get in there. Some of the diagnostic clues that are helpful here are the pustules that you see in the periphery. So peripheral pustules are a common feature for candidiasis, and when you see that, you should definitely consider candidiasis as a diagnosis. Here's a patient with oral candidiasis. So remember, this can be scraped off, but if you do, there'll be some bleeding underneath, in that contrast to the oral hairy leukoplakia that we talked about before. Here's a patient with candidiasis just in the corners of her mouth. So we call that perleche, and that's related to malocclusion. So maybe her dentures don't quite fit, or for some reason the mouth doesn't close the way it should, and so that skin ends up being sort of macerated and ends up being an open place for the Candida to go and reproduce there. In terms of treatment for Candida, topical antifungal agents are usually all that you need, although this is one time where it's reasonable to use a topical steroid in addition to an antifungal medication, because Candida can be pretty inflammatory, and a lot of times patients are really itchy in association with this. So a low-potency topical steroid in addition to an antifungal medication is reasonable to do in the setting of candidiasis. And then, of course, areas that are moist, you want to keep them dry. That's the aluminum acetate soak again, the Burrow soak, and also using an absorbent powder, and they make some good ones with antifungal ingredients in there that can be helpful for treatment as well as prevention. Here's a patient with tinea versicolor, and this is what I was telling you about, how you have to have a dermatophyte organism in order to call it a tinea infection. So really a more appropriate name for this is pityriasis versicolor, because this is not caused by a dermatophyte organism. Here's a closer look, and what you're looking at here are hyperpigmented patches with easily elicited scale. So it may not look all that scaly here in this close-up picture, but this is an area that was just recently scraped right before the picture was taken in order to do a KOH examination. So scale that's not always obvious, but is very easy to elicit with just a little scrape right across the surface. So again, tinea versicolor, not caused by a dermatophyte. If you want to be completely correct, then you would call it pityriasis versicolor, caused by lipophilic yeast, that same Malassezia furfur, which on KOH looks like spaghetti and meatballs. That's the classic description for it, as opposed to that filamentous hyphae that we were looking at with the dermatophyte infection. Patients can have light or dark spots on their skin, and different patients may have different findings, but within one patient, you'll usually see the same thing. So you won't see light spots in one place, dark spots in another. Within one patient, you'll usually see the same morphology. In treatment here, is topical selenium sulfide does very well. Having people pick up a regular selenium sulfide containing shampoo next time they're at the pharmacy, using it like a body wash. So patients usually lather up with it, allow it to stay in place for 5 or 10 minutes, and then rinse it off every day for a couple of weeks, and then use it a few times or maybe once a week or so indefinitely thereafter to try to prevent recurrence. Topical azoles work just as well. Sometimes patients, I did have one patient who didn't have access to regular showers, and so ketoconazole cream was a good option for that patient. You can use ketoconazole shampoo, and sometimes we even use ketoconazole orally, especially you can imagine patients with really widespread involvement. It's not feasible to rub a cream over a large area like that. So there are a lot of different dosing regimens, and they all work pretty well. Again, tinea or pityriasis versicolor, and this is a patient showing hypopigmented patches instead of the hyperpigmented patches that we were looking at with the previous patient. And here again, pretty monomorphous here, patches, and if you just scraped even a little with your fingernail, you'd see a ton of scale that's there. Here, this patient has a little bit of erythema associated with it, so you can see kind of tan, but also kind of pinkish here. And you can still see that kind of annular shape of the lesions, but some confluence here to a larger patch. And here's that classic appearance under the microscope. If you get really, really lucky with your KOH, it will look like this. So I say you have to be lucky because it's unusual for all of the keratinocytes in the background to be completely dissolved by the KOH, and usually you have to kind of hunt and look in between a little bit. But this is a nice clear picture showing those spaghetti and meatballs, which are the yeast forms and the hyphal forms. Again, for treatment, you can use ketoconazole or selenium sulfide shampoo. It's important to know that the selenium sulfide you get across the counter is 1%, but by prescription you can write for 2.5%, and it comes as a lotion by prescription, but patients still should use it as a shampoo like a body wash. Terbinafine can be used topically, but it's not effective orally, so a PO course of terbinafine is not going to do it for you here. And then again, oral medications can be used, and the ketoconazole shampoo or selenium sulfide shampoo are helpful for prevention, and that's used intermittently. So here's our patient again, the 28-year-old school teacher with a scaly patch of alopecia. Culture confirms tinea capitis. What are you all going to treat her with? Okay, good. So oral griseofulvin is the treatment of choice here. Remember, topical treatments are never going to be enough to totally clear tinea capitis, so tinea capitis requiring oral medication. Let's talk about Rocky Mountain spotted fever up here first, and here's a tick that may be conferring that rickettsia organism to cause Rocky Mountain spotted fever. You can see its mouth parts there right into this person's skin. So the causative agent for Rocky Mountain spotted fever is that Rickettsia rickettsii. It's transmitted by the wood tick or dog tick or Dermacentor species. Usually requires a few days of incubation, and within that time, patients develop constitutional symptoms, and they also develop a rash that typically begins on the wrist and ankles with erythematous macules and subsequently spreads to involve the hands and feet with petechiae, and then generalizes after that. It's important to know that about 10 to 15% of patients are suggested to have Rocky Mountain spot-less fever, and that's more frequently diagnosed in more darkly pigmented individuals, and it's thought that the spots or the typical rash of it is less visible or more difficult to appreciate in darkly pigmented individuals. This typically occurs in the sort of southern Atlantic part of the country. North Carolina and Oklahoma are big common areas where it's seen a lot, so I don't know if anybody is from those places, but those are where you see it the most. And even though it was initially described in the Rocky Mountains, only a small percentage of cases are diagnosed in that area these days. So here's a kind of generalized, once the eruption gets more generalized, and we're looking at erythematous macules and patches here, and maybe some petechiae towards the center here of Rocky Mountain spotted fever. Treatment, I know you'll go over in detail a little bit more in your infectious disease section. Okay. Here's our next question for consideration. Rash most commonly associated with Lyme disease. A lot of erythema there, so you got to think about the rest of it. Keep that in mind. And let's talk about Lyme disease next, sticking with the tick-borne illnesses. Causative organism here is Borrelia burgdorferi, and this is transmitted by a different tick, the Ixodes species tick. And the eruption associated with Lyme disease is erythema migrans, or sometimes we call it erythema chronica migrans. And this is that expanding bullseye, so I'll show you some examples in just a minute. Lyme disease, as you know, can have a multi-organ system involvement, including cardiac, neurologic, and patients can have arthritis as well if it goes untreated over a long period. So here you can see a typical targetoid lesion of erythema migrans with the tick bite right here in the center, and then that erythematous patch that's expanding around it. Here again, another example, you can see the tick bite in the center and then an expanding erythematous patch around there. In terms of treatment for Lyme disease, a lot of times the serology is not readily available. It can take a long time to get back, and so treatment when you see a patient with erythema migrans is not unreasonable to go ahead and get started. Doxycycline is used most frequently, and in patients who don't respond to appropriate treatment, you might look for the HLA-DR4 allele, because that's the circumstance where you would see that. Okay, here's our next patient. It's a 33-year-old man with pink macules on the palms and soles. He's got an RPR and VDRL that both are positive. What stage of syphilis does this patient have? So keep that in mind. Syphilis, caused by Treponema pallidum, is a spirochete organism that you're looking at here. It's motile, and it moves like a corkscrew, and it also bends in the middle. Syphilis is divided up into stages. A primary syphilis consists of a painless chancre, and I'll show you some examples of that, and kind of hard to believe that it could be painless when you see what it looks like, but nonetheless, it's classic painless chancre. Usually lasts for up to a month or so, maybe a little bit longer, and then resolves on its own even without treatment. So if this is in the right place where patients don't notice it, it can definitely go completely undetected. So here again, hard to imagine that could be painless, but I suppose it could. Here again can be multiple, so patient with multiple syphilitic chancre. Does not have to be limited to the genitalia in any place where the organism is inoculated. So this may be an old picture of, say, a pathologist who was doing a autopsy and came in contact with it that way or some other way. can be on the mouth as well. So a syphilitic chancre here. Moving on. Another. Secondary syphilis occurs a couple of months after infection. So once patients get over that chancre, then they develop secondary syphilis. And this is a type that is sometimes called the great mimicker. So this can have a lot of different clinical appearances to it. Nickels and dimes and those ham-colored macules describe the places that you can see on patients' palms that are typically kind of a pinkish color, but a number of different eruptions, including a pityriasis rosea-like eruption, are common in secondary syphilis. This too resolves on its own, even without treatment, in about 3 to 12 weeks. Treatment here again, penicillin. So here are some palms with those ham-colored macules here, kind of a pinkish tan color on the palms, and can be seen on the soles as well. This is an eruption that kind of looks like pityriasis rosea, so remember that's a viral exanthem with these oval hyperpigmented patches with a little bit of scale on there. Here this patient has, this looks a little bit like the sarcoidosis that we looked at before, and this would definitely require a biopsy in order to have a clear-cut diagnosis here, but an eruption of secondary syphilis. Here's condyloma lata, so genital warts with secondary syphilis. Here's a mucus patch, so what we're looking at is kind of a large erosion on this patient's tongue, which is also a feature. And then latent syphilis, so patients get kind of a break here, a time frame where there really are no signs or symptoms, but those tests, the VDRL and RPR, remain positive during this time. And then finally tertiary syphilis, which can have involvement of many different organ systems, particularly CNS involvement. Patients have tabes dorsalis, which remember is a demyelinating disorder which results in neuropathy and can ultimately result in paralysis. You remember the Argyll-Robertson pupil, which is that prostitute's pupil that accommodates but doesn't react. The gummas, or destructive places in the skin, I'll show you some examples of those. And then that should be 18 or 24 million units of penicillin. So here's a gumma, just a destructive ulceration here on this patient's nose. And we'll see it can be quite destructive going through layers of skin. So this patient's developed a hole in the hard palate as a result of a syphilitic gumma. Malperforans, or an ulcer related to neuropathy on this patient's foot here. And a Charcot joint, so again related to neurologic damage, joint dysfunction. And here's a question here for your consideration. 18-year-old man who complains of fever, malaise, and sinus discharge, as well as a hacking cough for 3 days. On exam, he's got small white vesicles on an erythematous base on the palate. What's his diagnosis? So we've actually already covered that, so everybody should have that in mind for when we get back to it, and I expect everyone to get it right. Let's talk about verruca. We're talking about other infectious diseases here. So verruca do not come from frogs, in contrast to what you might have heard. Verruca vulgaris, the common wart caused by a lot of different HPV subtypes, frequently seen on the hands and feet, in kids and adults in particular. When they're on the feet, we call it verruca plantaris, so we'll come back to that. In general, we don't have any treatments to work against the virus itself, but what we try to do is get rid of the place where the virus lives, so we get rid of that superficial layer of the epidermis that's infected with virus. The best way to do that is with destructive methods, so cryotherapy like liquid nitrogen, salicylic acid, which is what's available in over-the-counter wart medications, and also the CO2 laser, which is also ablative for that superficial layer of the epidermis. Couple of common warts here. Classic verrucous surface. Here again, a verrucous surface, multiple in numbers. If you see a lot, you might consider looking for immunodeficiency in a patient, but that's not necessarily the case. Verruca plana, or flatwarts, are also caused by HPV, but different types of HPV cause flatwarts as opposed to Verruca vulgaris. These tend to be sort of flesh-colored or pinkish in color, and again located just about anywhere, but on hands and arms is a common place to see those. Verruca plantaris, some specific HPV types here, 1, 2, and 5, located on the soles of the feet. These usually are painful for patients because they have a lot of pain when they put pressure on top of these sites. Treatment is similar to the Verruca vulgaris with destructive methods. They often get paired in the clinic, so just cutting down that thickened skin right there on the surface. And then condyloma acuminata, bad news all the way around, genital warts. HPV type 6 and 11 are the most common causes, and fortunately those are not associated with malignancy. However, 16, 18, and 31 are very bad news because those are associated with cervical cancer, but on the plus side, they are included in the HPV vaccine that's available now. Treatment here, same thing. We don't have anything that works directly against the virus, but we try to get rid of its home with podophyllin, which causes necrosis there. Liquid nitrogen sometimes used, and imiquimod, which is a topical agent that stimulates a local immune response so that patients can clear away verruca on their own, or condyloma. Here's an example. Sort of similar to the Verruca vulgaris appearance with that verrucous surface, but on a mucosal surface here. Here again can be quite extensive. And here again, condyloma that are perianal in location. And sometimes they can lead to malignancy. So this is a patient who started out with condyloma and ended up with a large squamous cell carcinoma. Still on the viral line, next up is molluscum contagiosum. This is caused by the pox virus. Classically looks like umbilicated papules, so kind of whitish or flesh-colored papules. Yeah, frequently seen in children, but by the time most of us get to be adults, we've already been exposed to the virus and tend not to develop molluscum. We do see them in people who are immunocompromised, particularly those with HIV, and they can be sexually transmitted as well, and the time to consider that is when you see them in the genital area. So classic appearance of molluscum here, kind of flesh-colored or a little bit pink papule, and if you look close you can see kind of a little dell right in the center, which is that umbilication. Sometimes when they're earlier or younger, like this one, you may not see that umbilication there, but that classic kind of whitish or pinkish appearance of a sharply defined papule is still a pretty classic appearance for it. And for them to be grouped in one area like this is pretty common as well. Next is herpes simplex virus. You remember this is dewdrops on a rose petal or vesicles on an erythematous base that usually occur in a group. We also don't have a cure for this, but and so it can be recurrent. This is a patient with herpes labialis, and in between, it tends to recur at times when the host is immunocompromised, and that might be even something as minor as getting a lot of sun exposure. Remember, we use ultraviolet therapy for treatment in things like psoriasis or atopic dermatitis, so ultraviolet light can be just enough to locally cause some suppression, immune suppression, that's enough to allow the herpes virus to recur. Also, febrile illness, so hence the term fever blisters, same thing here. Here's an example of clustered vesicles here on this patient's genitals. And if you do a Zank prep, which means opening the vesicle and doing a scrape at the base of the vesicle, so remember that's in contrast to looking for the dermatophyte and vesicular dermatophytosis. Here now to look for herpes viral findings, you scrape the base of the vesicle, and what you see under the microscope is a multinucleated giant cell, and that's what we're looking at right in the center here, is a large multinucleated giant cell, which is indicative and diagnostic for herpes simplex viral infection, or herpes viral infection. So here again, a cluster of vesicles, an erythematous base. on this patient's lip, so herpes labialis. Here, a cluster on the patient's fingers. And the same findings. This is getting a little bit cloudy, so maybe an older vesicle that now is looking more like a pustule, but you still have that nice erythematous base there. Something you might consider in the differential here is that gonococcemia, because remember that was a vesicle with the purpura in the background, but this is kind of a lot, so you don't tend to see those gonococcemia pustules in clusters like this. When you see those clusters, you definitely need to think about HSV. Here's a patient with pretty widespread involvement, and here, even though the vesicles are no longer intact, you can still see these round erosions with some confluence here into these larger erosions, but you can still kind of see the outline of where those vesicles used to be. This patient may have a sunburn or some other damage to the skin that's resulting in a more severe, more widespread, could be even eczema herpeticum, remember a complication of atopic dermatitis that we talked about. Here again, this is an immunocompromised individual who really has developed ulcerations as a result of herpes simplex viral infection. Unusual in an immunocompetent individual, but here again, in some places you can still see those punched out ulcerations from where the vesicle used to be, and you can see the scalloped border through here, indicating where those vesicles have now become confluent there. Another immunocompromised patient with a very widespread HSV infection, and even here the morphology is still relatively maintained with vesicles here in a large area and then sort of a hemorrhagic crust right on top there. So the varicella-zoster virus is also in the herpes virus family. So a Zank prep from a patient with varicella-zoster virus is also going to be positive. So just for clarification, the Zank is positive in all the herpes viruses, and it can't distinguish one from another. Varicella-zoster virus can cause two different disorders. It can cause varicella or chicken pox, where vesicles occur in crops and resolve in crops. So what you see are vesicles at various stages of maturity. And that's in contrast to, say, smallpox, because I know you remember that smallpox are all in the same stage of development at the same time. Herpes zoster is also caused by the varicella-zoster virus, also known as shingles, and that looks like vesicles in a dermatomal distribution. So let's look at some examples of those. Here are chicken pox. Vesicles, again, a nice vesicle full of fluid there is going to be a good place to do your Zank prep and look right from the base for those multinucleated giant cells. But you can see here some that appear smaller and that are sort of younger, and then another with kind of a crust on top that may be older. So various stages of evolution here. And then here's a patient with shingles related to varicella-zoster virus. So you can see that nice dermatomal distribution. For the most part, it stays on one side, although it's not out of the question to have a couple of vesicles here and there that cross the midline. It's a good idea to have it in your mind that it should not, but the reality is occasionally you can get a few vesicles that are even across the line. You can see this is pretty significant. These sort of darker areas look like the patient may have some necrosis there and may get some ulceration. Another patient with shingles. This patient is showing something called Hutchinson's sign, which you probably remember hearing about before. That's when patients have involvement of the nasal tip with varicella. It indicates involvement of the nasociliary branch from that ophthalmic nerve, or V1. And so this is a circumstance where you need to get ophthalmology involved pretty quickly. So again, when you see that nasal tip, Hutchinson's sign, call for ophthalmology consultation for sure. And here again, another example, kind of a lumbar dermatomal involvement here with vesicles in that erythematous base. Children are not immune from getting varicella. So here's a patient with a V1 distribution of shingles, but notice his nasal tip is not involved, although he looks like he may have some ophthalmic involvement as well. So probably a good idea to get the ophthalmologist to see this patient as well. And then even infants can have shingles. So here's an example of that. And in all those cases, again, your Zank prep's gonna show a multinucleated giant cell, just like we're looking at right in the center here. We're moving on. Next, we're going to talk about pityriasis rosea. And this is a viral exanthem that shows hyperpigmented patches that have a fine amount of scale that usually is limited more so to the periphery, because I know that you're thinking that sounds like tinea versicolor, and it can kind of look like that. But I'll show you some examples and hopefully you can see some differences there. Classic appearance for pityriasis rosea or classic distribution is going to be on the trunk, but sometimes the extremities can be involved, and usually this is asymptomatic, but the appearance of it can be unsettling for people sometimes, and it's usually the appearance that brings folks in. Classically occurs along the lines of cleavage, so this is the one that's sometimes described as looking like a Christmas tree on the patient's back. It's self-limited. So here, the herald patch kind of heralds the appearance or the development of pityriasis rosea. It's usually the largest patch and usually and always the first one to appear, although sometimes patients don't notice when they've developed a herald patch. They just notice when the rest of the eruption occurs. So a little bit of scale here. And then this is a patient with full-blown pityriasis rosea, and what I want you to appreciate is these are kind of oval, and they kind of go along with the skin lines of cleavage. So if you think about lines of cleavage going kind of along down this way, the papules sort of follow that line. Looks like a Christmas tree. Okay, now we've gone from a viral exanthem to a critter disorder, so scabies, caused by the scabies mite, Sarcoptes scabii. The female mite burrows in the stratum, just within the stratum corneum, and creates what look like burrows, or what we call burrows on the surface of the skin. Kind of looks like a little white line. And then at the very end of that, if you're fortunate, you'll see a little black dot, which is your scabies mite that you can scrape off the patient and look at under the microscope to confirm the diagnosis. So the best place to look for those mites and for the burrows is particularly on the hands, especially the web spaces, but other places you can look on the feet as well, and also in double covered areas like on the breast and the groin area. So patients are extremely itchy with scabies. This is a patient that will be taking every antihistamine that you can think of and still may be in tears and not sleeping at night because the pruritus is extremely severe. It's classic for them to itch more at night, and we sometimes think that that's associated with not having the regular distractions of the day to distract you, and so all you have to think about is how much you itch. But these patients do a lot of scratching and a lot of itching. Here is a person with scabies, an involvement on the hand, and mostly what you can see here are places that have been scratched. So you may not be able to get a diagnosis just from looking here, but if you look closer, you might see something that maybe resembles a burrow or looks like a good place where you can do a scraping and get that mite to confirm the diagnosis. As I said, in the genital area, you can see as well. And this patient has a few erosions and crust top papules here from doing a lot of scratching in this area. Scabies in children doesn't really mind any border. So as I told you, in adults we think of hands, feet, genital area, but in kids can really be all over. So this is a patient who's been scratching and itchy all over with scabies. And then this is crusted scabies. So this is seen in patients who are usually non-mobile and don't do a lot of scratching. So in the other patients we saw, one patient might have half a dozen or maybe as many as a dozen mites causing all of their pruritus, but in a patient like this, all of this crust is just chock full of scabies mites. So this person is going to be highly infectious, but very easy to diagnose because you just need to scrape a little off the top and look under the microscope, and you'll find a scabies mite. So here's a mite here, and then this is an egg casing, or open egg casing, and maybe an egg that's still full here. So with that in mind, guess what this is? So little droppings there. So with the scraping, you really can make a diagnosis if you see any one of these three findings from the patient's skin. Here again, a closer picture of a scabies mite here, and then here you can see an egg that's there as well. I don't see anybody itching in here yet. All right, so treatment for scabies. Permethrin 5% cream is really the first line treatment that we use. Have patients put it on at bedtime, leave it on overnight, and wash it off in the morning. This is a circumstance where it's important to treat everybody in the house at the same time. Permethrin is very good at being scabicidal, but is not great for the ova. And so any ova that make it past the initial application have been hatched and are busy at work by the time you get to the second application, and that's the reason for doing that. So that's to get after any eggs that hatch after the first application. Lindane cream is sometimes used as an alternative, but you have to be careful with that because it can cause some CNS toxicity. Definitely not for use in kids, and not for use in pregnancy either. So from one critter to another, if you're not scratching already, you might be by the time we finish with this section. We're going to talk about lice now. Head lice, seen most commonly in school-age children, caused by the organism or the mite Pediculus humanus capitis, can be treated with permethrin, which is what's in most of the over-the-counter products. But there is emerging resistance for head lice. Body lice are more so associated with unsanitary conditions. So usually treatment with bathing and laundering of clothing in particular, because they like to be in the folds of clothing, in the seams of clothing, is adequate treatment there. And then pubic lice, which can be sexually transmitted, caused by Thyrus pubis, can be treated with lindane or also pyrethrins. So here is a patient with head lice, and you're not looking at the louse here, but all of these little spots in the hair are actually nits. So these are eggs that are cemented in their little casings onto the shaft of the hair. There's something called hair casts, which are made up of oil and keratinocytes from the surface of the scalp that can mimic a nit and look like a white thing stuck to the hair shaft. But the difference is that a hair cast can be moved easily and slid off of the hair, but these nits are really cemented to the hair shaft. So if you grabbed onto this and you pulled it, you wouldn't be able to move it out of place. You can distinguish about how long the infestation has been present based on the distance of the nit from the surface of the scalp. So once they get more than an inch or so away from the scalp, you can pretty much determine that that's not going to be a viable nit, because remember, they feed on the blood supply from the scalp. So as the hair grows out, the nit stays in the same place and it gets further and further away from the scalp. Here's an example of body lice. So here within the seams of this patient's clothing, here's the louse itself. Notice it has kind of a large body, and that will be in contrast to the crab louse or the pubic louse that I'll show you in just a second. Here again, the body louse, that kind of wide body. And here's one in action at the surface of the skin. Now this is pubic hair, and here we're looking at the nits along the hair shaft, so sort of similar to what we saw on that patient's scalp before. You may not see the louse itself, but here we can see a lot of nits. here's kind of a far away view of the pubic louse, but you can kind of appreciate even from here the difference in the body shape. So that's why this one is sometimes called the crab louse, or the infection is sometimes called crabs, because it looks more like a crab and has these little kind of graspers on either end, which I'll show you a closer picture in just a bit, but they are almost exactly the right length apart to correspond to the distance apart that pubic hairs are usually located. So this is an organism that really is highly evolved to serve its purpose. Here again, we're looking at some knits within the hair here. Sometimes head lice can get down and involve even the eyelashes. So if you look right here along the lid margin, you can see some knits in that area as well. Here's the pubic louse. So again, kind of looks like a crab, and it's got those claws that are just far apart enough to grab one pubic hair on each side. And here's a knit there, and you can kind of see that cemented casing here where it's attached to the hair shaft. And a closer view in case you're not itchy. All right, so let's go back. The rash most commonly associated with Lyme disease. Here's your chance to vote. Okay, good. So erythema migrans. And the 33-year-old patient with the pink macules and the positive RPR and VDRL, what stage of syphilis does this patient have? Okay, good. So secondary syphilis, which we know by the positive serology, and also those ham-colored macules on the palms go along with secondary syphilis. All right. Oh, here was our 18-year-old with the fever and malaise and the white vesicles on an erythematous base. So what was this patient's diagnosis? Okay. All right, so kind of a mixed bag there, but remember the question described the Koplik spots, those white vesicles on an erythematous base. So this was a patient with measles. Okay. All right, that's my cue to tell you we're on the home stretch here, so stay with me. All right. So now we're going to talk about skin cancers. First up is basal cell carcinoma, and the reason that this one is first is because this is the most common skin cancer there is, approaching 1 million cases now per year. This is fortunately the least invasive type of skin cancer that there is, and for a little while there was even a debate about whether to call it a cancer or not. They used to call it basal cell epithelioma instead of carcinoma. It invades locally, but slowly. Takes about 6 to 12 months in order for one lesion to double in size, and it rarely, if ever, metastasizes. Affects women more frequently than men, and is associated with cumulative sun exposure as well as with short bursts of sun exposure. And so this is something usually seen in adults, people 60 years and older, and certainly in sun-exposed areas. So the head and neck are common places to see it, but not limited just to those areas. As I mentioned, related to chronic sun exposure can sometimes be seen in immunosuppression, but squamous cell carcinoma that we'll talk about next is more frequently seen in immunosuppressed individuals, and it is associated with people who have very light skin types. So here's a classic example of a basal cell carcinoma. This is a good one to have in your mind. Translucent or kind of a pearly border here, and then you're looking at lots of little telangiectasias, those blood vessels that are prominent right on the surface there. Sometimes it can ulcerate in the center, and it's referred to as a rat bite ulcer or rodent ulcer. But typically, this is a pretty good appearance for it. Based on the size, it's probably been present for a couple of years or so, because remember I told you this is a slow grower. Here's another, that translucent appearance here. Can't quite appreciate the telangiectasia in this case, but they are there. Sometimes can be more superficial, and this is a pretty large lesion here as well. The papular portion of it still has that kind of translucent appearance, but in between can almost look sort of eczematous, and that's a finding of a superficial basal cell carcinoma. So if you have an eczematous patch that doesn't respond to standard treatment, you might be concerned about a skin cancer, a basal cell there. Here's one that's gone neglected for a long period of time, and it's got a very large outline here involving the patient's eyelid margin all the way back to the tragus here and in front of the ear with an ulceration there. So this patient has some scarring in the wake of their basal cell carcinoma, and we sometimes call that a morpheaform type of basal cell. So this has definitely gone on untreated for a long period of time because it's pretty unusual for them to get quite so large. As I mentioned, more common in lightly complected individuals, but not limited to those. So this is a basal cell carcinoma in an African American individual, and this one has some pigment to it, so we would call this a pigmented basal cell carcinoma. Still keeps the morphology for the most part, papules that are here, but again, you wouldn't be able to appreciate telangiectasia nearly as well because of the dark pigmentation. And then, as I mentioned, if it goes untreated for a very long time, and this is probably decades of neglect, it can become locally invasive. So this is probably the skull margin that we're looking at here with marked invasion. So long time neglected. Squamous cell carcinoma, second most common skin cancer. And it has a greater metastatic potential compared to basal cell. And squamous cell in particular locations is much, much more likely to metastasize, and that's places on the head and neck, especially in front of the ears and along the lips as well. This occurs more frequently in men as well, and this is a skin cancer of mature adults in sun-exposed areas. And again, more fair-skinned individuals are more likely to develop it, but they're not the only ones who can develop it. Squamous cell carcinoma can occur in the setting of chronic ulceration. We call that Marjolin's ulcer. You might be familiar with that. And it also can be induced as a result of HPV infection, and that's thought to be how immunocompromised individuals get a lot of squamous cells, because they have HPV infection that is allowed to sort of go unchecked or to advance. So here's a squamous cell carcinoma. Flesh-colored or erythematous. A lot of times they have a fair amount of scale that's associated, but you don't see that in this picture. They can have kind of a warty surface and can ulcerate similar to the basal cell. These usually are pretty firm nodules when you see them. Here's an example on the foot, so probably a less sun-exposed area, but a squamous cell here just the same. And this kind of lower portion is pretty typical in appearance. A lot of erythema, that kind of crust and scale that's right on top there. And then this has kind of an eroded surface back here a little bit. This is a particular kind of squamous cell carcinoma called keratoacanthoma, and this is sometimes described as looking like a volcano. So it's a large erythematous papule with a central kind of crust in there. Typical history for this is for it to have evolved or developed very quickly over a short period of time, like a couple of weeks, and then some of these spontaneously resolve, while others can go on to metastasize. So I can tell you just really quickly, when I was a resident, I had a patient at our VA hospital who had a keratoacanthoma like this. He came in and I referred him to the surgeon, and then I got an alert that said that he had missed his surgical appointment. So I called the patient and I said, "Sir, you know, this is really important. You missed your appointment." And he said, "Well, I would have gone, but it went away all by itself. The thing just went away." So it cleared up completely, and sometimes they do spontaneously resolve, but we can't know from looking which ones are going to resolve and which ones are going to metastasize. So it's a good idea to just remove all of them. sometimes can be very locally invasive. And here you can see maybe originated behind the ear. It's hard to know exactly where this started from, or if it was down here maybe, but you can see erythema and edema of the ear itself. So this patient's probably going to have to lose his ear in the treatment, which is surgical excision for the squamous cell. And here again, another example of a patient that probably started out with an HPV infection that went untreated and ultimately developed a squamous cell carcinoma there. This is an example of a squamous cell in the setting of chronic skin damage related to radiation. So what you can see around here is that the skin in this whole periphery is not normal. This is a patient who had undergone radiation for an underlying malignancy and then ultimately developed an ulceration here and developed a squamous cell carcinoma within that ulceration. And then, as I said, not limited only to fair-skinned individuals. So here is an African American with a squamous cell carcinoma on the lower part of this lip. Now, I know everybody has noticed that he's got some pigmentary abnormalities, and this is a patient with discoid lupus. I know you're all thinking that because it looks like the pictures that we looked at before. Remember, hypopigmented or depigmented center, and then a hyperpigmented rim around that. So the places where there's depigmentation, there are no melanocytes, and so this is the same as being very fair-skinned or even having vitiligo. So this skin is very, very susceptible to UV-induced damage, and this patient has developed a squamous cell carcinoma on the lower part of the lip, which was already depigmented from his discoid lupus. Here again, a squamous cell developing in a chronic ulcer. This may be a venous ulcer on this patient's leg with a squamous cell that's developed within that. Here's our next question for consideration. Which of the following is most important in determining the prognosis of a patient with melanoma? A couple things to think about there. So next we'll talk about melanoma. Melanoma, it probably gets the most press because it certainly can be the most aggressive, or is the most aggressive of the three that we've talked about here so far. It can have variations in color and shape and size and border. That's that A, B, C, D, and we'll talk about that some more in just a bit. The splitters got a hold of melanoma as well and divided it up into several different clinical variants. So we'll talk about each of those here briefly. Let's talk about the ABCDs here first, though. Clinical appearance. So these are, first is A for asymmetry, and that basically means you should be able to draw a line through any pigmented lesion and have it look the same on one side as it does on the other. So when you see asymmetry, that's a bad finding. B is for border, so we like to see a nice sharp even border as opposed to one that is scalloped or one that fades out into the periphery. C is for color, and we like to see a nice even color as opposed to one that's light in some areas and dark in other areas, or maybe has red parts to it or blue parts. D is for diameter, so most normal nevi are about 6 millimeters, or the size of a pencil eraser or less. If you see something larger than that, that can be suspicious. And then finally, E for elevation or for evolution. So if something that used to be flat becomes raised, or something just changes from what it was like before, those can also be indicators that something's going on. So the different types of melanoma, first up is superficial spreading melanoma, and this is the majority of melanomas that occur in Caucasian individuals. You can see pretty young median age. We see these in people on both sides of that, and this frequently occurs as a change in a pre-existing mole that grows peripherally, so it has a radial growth phase, and it's called superficial spreading. Lentigo malignant melanoma is seen more frequently in more mature adults, people who are 65 and usually beyond that. This is something that slowly evolves and often has some variation in the color and can get pretty large before patients are diagnosed. So here, when you think about those A, B, C, D, this is bad news all the way around. It's asymmetric. The border is not even here. The color, it's got light areas and dark areas. The diameter is certainly greater than a pencil eraser here. And there's a good chance that this has changed as time's gone on. So this should definitely send up some red flags for you. Ideally, when you see a pigmented lesion in a patient, what you want to do is remove the whole entire thing as soon as you see it. But for something like this, that's not very feasible, and so there's sort of an ongoing debate in the dermatology and dermatopathology world about the best way to biopsy something like this. And usually what it amounts to is taking a couple of biopsies from several areas where you think that things might show the worst, the most atypia. So for here, you might biopsy kind of the darkest areas. Acral lentiginous melanoma is the type of melanoma that's seen most frequently in darkly pigmented individuals. So this accounts for the majority of melanoma in African Americans. Typically occurs on acral surfaces, as the name suggests, so we're talking palms and soles here, but also can be in nail beds. So it's important to look at patients' nails, looking for lines of pigment that are new or that are changing, as opposed to those that have been present for a long time. Now, in darkly pigmented individuals, pigmented lines in the nails are a frequent finding, and so in that case what you want to look for is uniformity one to the next. You want to look for similar degree of pigmentation, a similar width of the lines, and in that setting it can be a normal variation. But if you see one that looks different than the others, similar to looking at moles in patients, that should be a site of concern for you. This is a different type of Hutchinson sign, and I know you remember the other Hutchinson sign was with the shingles and the nasal tip involvement. This is Hutchinson sign in acral lentiginous melanoma, where the patient has pigment that extends up onto the proximal nail fold. So that's another thing that can help you distinguish normal pigmented stripes in the nails called melanonychia, which will not have Hutchinson sign, compared to melanoma in the nail, where you do see Hutchinson sign, which again is pigment on that proximal nail fold. Now that will not always be present when melanoma is there, but that definitely can be a bad sign. And acral lentiginous melanoma can be quite destructive. So this is a patient who has lost their nail and has some ulceration as a result. Here again, less pigmented here, so this might be difficult to pick up without doing a biopsy here for sure. Nodular melanoma has a vertical growth phase as opposed to the radial growth phase that we looked at with the superficial spreading. So this one usually comes up de novo, comes up from a place where there was not a mole and grows very quickly into a nodule. And here again, just thinking about the ABCDs, it's asymmetric, the border is notched here. The color with this red portion in addition to the pigmented portion, all of those are bad indicators. These usually are pretty rapid growers over the course of a few months, so patients should not be getting new moles once they get out of their mid-20s or so. So a patient who comes in and says, yep, I just developed this new mole over the last few months and it's gotten larger in a short time, that should definitely send up your sensors that this might be a melanoma, particularly a nodular melanoma. When talking about the prognosis, the depth is the most important feature. So you can see here there's a big difference in long-term survival from patients with more superficial, i.e. less than 3/4 of a millimeter. They have 99% 5-year survival, whereas patients who have more than 3.5 centimeters of thickness have a less than 50% survival rate. And that's a quite literal thing. So when you remove the entire mole, looking at it under the microscope, the distance from the surface of the lesion to the deepest most portion is the thickness of the melanoma. And again, that's the most important thing when determining the patient's prognosis. There are other things that can be good prognostic signs. Younger patients tend to do better than those who are older than 50, and patients who have melanoma on the trunk tend to do better than those who have melanoma on their arms or legs, on their extremities. Next up is cutaneous T-cell lymphoma. So we've kind of moved out of the realm of ultraviolet-induced skin cancers, and now we're talking about T-cell lymphoma, a form of lymphoma. Mycosis fungoides is one particular type of cutaneous T-cell lymphoma, and this is caused by a clonal expansion of CD4 positive T cells in the skin, and it's pretty uncommon, although in a busy dermatology practice we see it pretty regularly. Patients usually develop erythematous patches, which progress onto plaques and then can become tumors or nodules. And a common distribution to see this is in double covered areas, so particularly in the on the buttocks and the genital area, as well as on the chest and back. Some patients with mycosis fungoides can go on to develop Sézary syndrome, which includes erythroderma. So remember, that's 90% or more of your body surface area involved. And that's in association with Sézary cells, which are atypical circulating lymphocytes that are seen on a peripheral smear, and they have a characteristic kind of cerebriform nucleus, so kind of looks like a brain with lots of curves on the nucleus there. So here's an example of a patient with mycosis fungoides looking at these erythematous patches. Again, the buttocks area is a common location to see it. A patient like this may be someone who has been treated for a long time for, say, atopic dermatitis, but hasn't really responded and may even be progressing. So again, patches that start out flat like this can develop some substance and become plaques, and then nodules and tumors as patients progress. Usually pretty asymptomatic. Patients are not especially itchy or have symptoms related to this. Here's a patient who's got a more advanced case, and here again we're looking at nodules in particular here across the patient's back and shoulder, but you can see down here some of it is still patch-like, and this patient's got the skin biopsy sign here, so this is definitely a biopsy diagnosis, and often patients have a very slow kind of development of it, so biopsies done repeatedly in a series, maybe every 6 months or so, are sometimes required in order to get those diagnostic findings to make this diagnosis. Here's a patient with tumors and nodules involvement of the face. So this is part of your differential diagnosis for leonine facies is mycosis fungoides. Here's a patient with erythroderma. So more than 90% of the body surface area involved with erythema. In a circumstance like this, you may be able to get the diagnosis from a biopsy here, but often when patients have erythroderma related to psoriasis or atopic dermatitis, a biopsy at the height of their erythroderma or during their erythroderma can be non-diagnostic, so that can be difficult. If the patient has a history of mycosis fungoides and then they develop erythroderma, it's safe to say that that's probably the cause of it. This is somebody you definitely would want to get a peripheral smear of, looking for those Sézary cells. There are a number of different treatments for mycosis fungoides. For small localized patches, sometimes topical steroids can be effective just for small patches. We use topical nitrogen mustard. Phototherapy is used sometimes, and when patients get to a plaque stage or tumors or nodules, then referral to oncology is certainly a reasonable thing to do. Paget's disease is intraductal carcinoma of the breast that then spreads onto the surface of the skin. So this is usually asymmetric and can look like kind of an eczematous patch. So here again, everybody should be a little, have a few reservations when you see eczematous patches that don't respond to standard treatment. You need to think about skin cancers in that setting. Remember, we saw the basal cell that can look eczematous. We just saw mycosis fungoides that can kind of look like that. And now we have Paget's disease that can look like that as well. Here, I'll show you an example here. So again, retrograde extension from that intraductal carcinoma, and just on one breast. And another thing that can be helpful in terms of diagnosis here is that if the nipple or areola are not involved, then you know that it can't be an extension from there. So in any case, a biopsy is going to be important here. Here again, an eczematous sort of looking patch just on one side with involvement of that nipple and the areola. And then the last thing to think about in the skin cancer section is other cancers that can metastasize to the skin. So lung cancer is one of those. GI malignancies can do so. Here's our melanoma, which can move from one part of the skin, metastasize to another, and breast cancer also metastasizes to the skin. So here's your chance to vote. What is the most important prognostic factor in a patient with melanoma? All right, good. So the depth of the melanoma is most important. And again, that's why you want to try to remove the whole thing so that you can see exactly where it is deepest, because that's going to be most important for prognosis. All right, here's a question for consideration. Which bullous skin disorder is associated with an anti-basement membrane antibody? So some choices here. And that brings us to bullous dermatoses. So we're going to talk about a few different blistering skin disorders. First up is porphyria cutanea tarda, and this is the most common type of porphyria, and it occurs as a result of a deficiency in this particular enzyme, uroporphyrin decarboxylase, or UROD for short. It's frequently seen in patients with liver disease, in particular alcoholic liver disease, or also patients with hepatitis C, so much so that when you diagnose a patient with PCT, it's important to check to rule out hepatitis C, see if they have it. In terms of lab studies, they'll have elevated copro and uroporphyrinogens, and clinically they develop blisters on sun-exposed skin, although they don't necessarily associate the sun exposure with the development of the blisters, but keeping that in mind, it gives you an idea for where you see those. So on the dorsum of the hands in particular, and can be on the face as well. Aside from the blisters, patients have just generalized fragility of their skin, and the blisters are subepidermal, and so they heal with scars and also with milia, which is a sign of a type of scarring. Patients with PCT often have hypertrichosis, and I'll show you an example of that. They tend to have a lot of hair, particularly on the face and the ears, and this is best treated with serial phlebotomy, unless to avoid iron overload in particular, and if patients have normal iron levels, then sometimes antimalarials are used, but they have to be used very, very cautiously and in much lower doses than you would use routinely, because if patients have liver disease, the antimalarial medication can make things worse, can exacerbate their liver disease. So porphyria cutanea tarda, we're looking at vesicles here in sun-exposed area on the dorsum of this patient's hands. You can see, let's see here, kind of healing with some scarring there. This patient doesn't have any milia in particular, but again, these deep vesicles that have left ulcerations and erosions on the dorsum of this patient's hands. Here's the hypertrichosis I was telling you about, and what you're looking at is right through here and along the patient's ear. That's just a greater than normal amount of hair that you would expect to see in that area. Variegate porphyria is another type of porphyria, and For this, the thing to do is think of porphyria cutanea tarda, so all of the things that we just talked about, in addition to systemic symptoms. Most frequently, abdominal pain is a common finding in these patients. Patients can have very severe abdominal pains, resulting in frequent trips to the emergency room, and sometimes they even end up having exploratory laparotomies looking for some kind of problem because their abdominal pain is just so severe. They can have neuropathy and also mental disturbances associated with this, and these patients are treated with glucose and Hematin for acute attacks. Now we'll talk about epidermolysis bullosa acquisita. So this is an acquired but autoimmune subepidermal blistering disorder that usually occurs in areas where there's a lot of trauma. So the hands and feet are a common place to see it. Patients develop blisters, and again they develop scars and milia, which are features that we see in subepidermal blistering processes. These patients have autoantibodies to type 7 collagen, which is right there at that dermal epidermal junction. So that's why they have subepidermal blisters. And here's an example of a patient with EBA, and you can see a few blisters here, kind of the fingertips and trauma-prone areas. Here you can see his other fingertips just barely. And if you look close, there's actually a large flaccid bulla that's here, but still has the roof on, as opposed to over here where it's kind of unroofed, large blister that's there. Bullous pemphigoid, which you may all be familiar with, an autoimmune blistering disease here, where patients develop large, tense, again, subepidermal blisters. These patients tend to be kind of itchy with their blisters, and in fact, early on there is an urticarial phase, or urticarial pemphigoid, which can occur before the blisters fully develop. These do not spread with lateral shearing, so if you put pressure right on top of one of these blisters, it would just rupture or nothing would happen, as opposed to spreading into the peripheral uninvolved skin, and we'll see that's in contrast to pemphigus vulgaris when we talk about that. Usually patients do not have mucous membrane involvement with bullous pemphigoid, and this is a disease usually of more mature adults, people who are 65 and older. Patients with bullous pemphigoid have autoantibodies directed against the basement membrane, so again at that dermal epidermal junction, and again a good explanation for having a subepidermal blister there. Sometimes can be induced by medications, and you can see the list of medicines that are there, and patients with bullous pemphigoid generally respond well to systemic corticosteroids, although for longer courses, we sometimes use immunosuppressing medications, and mycophenolate mofetil can be pretty effective for bullous pemphigoid. Here's an immunofluorescence, and what you're looking at is autoantibodies deposited here right along that basement membrane zone. So everything up this way is epidermis, everything down here is dermis, and this is the junction right there between the epidermis and the dermis. Here again, tense, intact vesicles and bulla. In some places you can see where there's been some erosion, where some of the bulla have opened, but for the most part these remain intact. Sometimes you can have pemphigoid that's limited to mucous membranes, and that's called cicatricial pemphigoid. Here you can see this patient has had some entropion, or kind of a folding in of the eyelid margin. Sometimes the eyelashes can scrape the cornea, and patients can have severe vision problems as a result of this. So bullous pemphigoid in contrast to pemphigus vulgaris. So these patients have thin-walled, flaccid bulla that often are already ruptured by the time they come in to see you. This is a disease of a little bit younger set of people, but still seen most commonly in adults, so we're talking 40s and up. Patients can have enlargement of the vesicles just by having pressure put on top of those. So again, that's in contrast to the bullous pemphigoid. Nikolsky sign refers to putting lateral shearing pressure on normal skin and that can produce a blister as well. And the reason for that is because these patients have autoantibodies affecting the desmosomes within the epidermis. And I'll show you the immunofluorescence so you can see instead of being lined up along that basement membrane, they're all within the epidermis and cause it to separate out and cause these blisters within the epidermis. So here again, putting pressure directly on top of the blister, and pemphigus causes the blister to spread out into the surrounding skin. And here is a H&E, the histology of pemphigus under the microscope. You can see that space that's in there, and you can see the basal cells are still lined up here right on top of the dermis, and then this is the rest of the epidermis that's separated, so you've got a space right in there. Again, an intraepidermal split, and the treatment here, similar to bullous pemphigoid with systemic steroids and immunosuppressing medications. Here's that immunofluorescence, and again you can see this, remember the pemphigoid was lit up just along the basement membrane zone, but here now we're talking about autoantibodies that are deposited all the way around the keratinocytes throughout the epidermis, so they cause a separation there within the epidermis. Here's another example, again ruptured and flaccid bulla with some erosions underneath there. And here again, the main morbidity with this comes from infection. So and non-intact skin barrier, patients can develop a localized secondary infection or even become septic. Here's a mucosal involvement in pemphigus vulgaris. So patients have erosions here, sort of similar to what they have on the skin. Okay, so we're moving on to dermatitis herpetiformis now. These are very itchy vesicles that occur in specific locations, usually on the knees and elbows, and mostly patients have scratched these enough by the time they come in to where they only have erosions, and you really don't see the vesicles with dermatitis herpetiformis. This is associated with gluten-sensitive enteropathy. That's important for you to know, and usually that's asymptomatic. Most frequent in people of Northern European ancestry, and usually responds very, very well to dapsone, but you have to check for G6PD deficiency before starting dapsone because methemoglobinemia is a side effect of dapsone and can be severe in patients with G6PD deficiency. So here's the immunofluorescence looking at dermatitis herpetiformis, and what you can see are these little lit up places here along the dermal papilla. So again, for orientation, we're talking epidermis here, dermis here. So the dermal papilla have IgA that's all lined up in there. So IgA is the frequent, is the causative autoantibody in patients with dermatitis herpetiformis. Here again, small vesicles, but you really don't see any vesicles in this picture here at all. What you see are erosions where a patient has been doing a lot of scratching. And here again, a classic location here on the extensor surface of the arm, mostly erosions and without any intact vesicles. But this is something to think about when an itchy patient comes in with that particular distribution. And a biopsy is definitely helpful here, especially with the immunofluorescence that we just looked at to confirm with the IgA. Another typical location, here you can kind of see the notion of where some vesicles maybe used to be, but now again all you see are those erosions that are present. So here's your chance to vote. Which of these bullous disorders is caused by an anti-basement membrane antibody? Okay. All right, good. So bullous pemphigoid is the best answer here. A few of you went for the other choices, but basement membrane, bullous pemphigoid. Okay. One for your contemplation. Eruption most often associated with which virus? So now we're going to talk about round lesions. Erythema multiforme is up first. This is a self-limiting disorder that we just looked at in that picture. So its classical appearance is that targetoid lesion with a dusky center, an edematous rim around that, and then an erythematous rim around that. So we'll look at a few more examples. It's most frequently associated with HSV infection, and so when you have a patient with recurrent erythema multiforme, it's important to check. It can be herpes labialis or genital herpes that's recurrent, and the erythema multiforme can recur with each HSV recurrence. This is also sometimes associated with medications, and you can see the list of medications that are here as well. Penicillin is just about on every list of drugs that can cause bad outcomes. So here again, erythema multiforme. This is probably one of my most favorite pictures in all of dermatology. You can see that dusky center here, and then a rim of white edema around that, and then an erythematous rim all the way out at the periphery. This one's probably the most classic right here. Again, that dusky center, an edematous rim, and then an erythematous rim that's all the way around that. Here's a patient showing us erythema multiforme on his hands. Here, this one you can kind of see the rim around it in association with herpes labialis, or that HSV infection on the lip. And here again, even from patient to patient, that classic targetoid appearance is tough to miss here. And this patient has some good targets, kind of down here, a little in closer to the wrists there. There's a good one. Does not have to be just on the hands. So here's a patient with erythema multiforme on the feet. And here another on the ankle, and still kind of maintaining that appearance, a dusky center, a little edema to the rim, and then erythema there at the periphery. Another round lesion is granuloma annulare. This is characterized by annular flesh-colored or sometimes a little bit hyperpigmented papules. Classically, a group of papules develop and coalesce into this round lesion, and there's usually clearing in the center. It looks completely normal through there. Common places to see it are on the extremities in particular, especially on the dorsum of the hands, and it's seen most commonly in women and children. Usually is asymptomatic and definitely is self-limited. So will go away without any treatment, but sometimes we use topical steroid to try and help expedite the exit of it. Now I know that some of you are probably thinking that looks just like the tinea corporis that we looked at way back when, and that's a reasonable thing to have in your differential diagnosis. This one happens to show a little scale there, but routinely there will not be much scale at all. And if you do a KOH like you would to diagnose the dermatophytosis, that's going to be negative in this case. Nummular eczema is another round lesion. Nummular means coin-shaped, so instead of being annular with a central clearing like we just looked at with the granuloma annulare, nummular is full. So this is a circle that's not clear in the center, it's fully involved in the center, hence being coin-shaped. These are eczematous patches, so kind of erythematous, edematous, maybe weeping like the atopic dermatitis eczematous patches that we looked at the very beginning. Typically located on the lower extremities and seen more frequently in mature adults and elderly patients, and usually it's pretty asymptomatic. To look at it, you would expect it to be kind of itchy, but for the most part it's not, and patients usually do well just with a good lubrication regimen, so that's where a little petroleum jelly can go a long way. So back to this question, eruption associated with which virus? Okay, good. Okay. All right, here's our next question. Which skin finding is most associated with the autosomal recessive polyglandular deficiency syndrome? Take a look at the choices. And this moves us to disorders of pigmentation. So here's our first patient with depigmentation along the fingertips and on the dorsum of the hands, and this patient's diagnosis is vitiligo. Right, so this is one of the classic distributions of it, sometimes called lip tip vitiligo. So patients have involvement around the lips, around the eyes, and on the fingertips. And here's a patient showing the other findings in that lip tip type. This is an autoimmune disorder where the melanocytes are kind of knocked out one by one, and patients as a result end up with depigmented macules and patches on the skin, but patients generally are otherwise very healthy. Sometimes there can be a personal or family history of other autoimmune disorders like alopecia areata, and sometimes it can be part of the autosomal recessive polyglandular deficiency syndrome. Here's another patient with vitiligo, but you can tell that in patients whose baseline pigment level is lighter, the vitiligo is less appreciable, but even on the patient's shoulder and here on the chest, you can see that there are depigmented patches as opposed to the normally pigmented skin here in the center. Here again, a patch of vitiligo on this patient's wrist, and depigmented. Remember from the patient we looked at with the squamous cell in the lip and the discoid lupus, the skin is especially photosensitive, so patients with vitiligo need to definitely use their sunscreen regularly. So we've gone from depigmented to hyperpigmented. This is a patient with acanthosis nigricans. So this is classically described as being velvety, so when you look at it, it's kind of thickened skin. Hyperpigmented patches, the axilla and the posterior neck are very, very common places to see this, and it's seen most frequently in obese patients and is indicative of insulin resistance, and often patients have a personal or family history of diabetes. Sometimes when it's very significant, or sometimes when it has an acute onset, it can be perineoplastic, and acanthosis nigricans is associated with gastric carcinoma in particular. So that's something important for you to keep in mind, and can also occur with niacin overuse. Again, acanthosis nigricans, a hyperpigmented kind of velvety patch in the axilla. This patient happens to have some acrocordons here, or skin tags that are scattered around, and it's not at all unusual to see those in association with acanthosis nigricans. Here again, in a patient's axilla, you can really appreciate that hyperpigmentation here. No skin tags on that one. And here's a posterior neck. So this is a very, very common finding, and unfortunately there's no quick or easy treatment for it. Even when patients reduce their weight through diet and exercise, the acanthosis nigricans often persists, but you can still kind of use that as a means to encourage patients to diet and exercise. Sometimes we use keratolytic emollients that have lactic acid or alpha hydroxy acids, which can sometimes be helpful, but again, tough to get rid of once that acanthosis nigricans has developed. Here involving the patient's nipple and areola. And here, pretty severe, but what you should be seeing is this kind of thickness here on the patient's hard palate, and even along the lip here is some thickening. And when you see it in a setting like that, that's when you definitely want to think about perineoplastic phenomena. So again, acanthosis nigricans can definitely be associated with gastric carcinoma as a perineoplastic finding. In terms of other pigment changes, ash leaf macules are hypopigmented or white, and I know that everybody is thinking about tuberous sclerosis when they hear ash leaf macules. Remember that has a constellation of other findings, including adenoma sebaceum, which are those angiofibromas that are located around the nose in particular. These patients have seizures and mental retardation, and also periungual fibromas. And then when you hear cafe au lait macules, I know you're thinking of neurofibromatosis. Patients who have 6 or more, depending on their size when you're a kid or when you're an adult, those can be used to make the diagnosis of neurofibromatosis. Can also be seen in Albright's disease, and sometimes when you have just 1 or 2, those are just a normal finding. These are some things that can cause diffuse hyperpigmentation, and you'll recognize a few things that we've talked about today already, like Addison's disease. Metastatic melanoma is something to think about. That's usually more of a bluish discoloration as opposed to just general increase in pigmentation, although sometimes you can just be overall browner with malignant melanoma. And remember, we talked about these nutritional deficiencies over here as common causes of diffuse hyperpigmentation. Some things cause diffuse hyperpigmentation that is most appreciable in sun-exposed areas, and that's where that pellagra comes in again. Scleroderma, remember we saw that kind of salt and pepper speckled appearance in the patient with scleroderma, and then certain medications and also porphyria cutanea tarda can cause sun-exposed hyperpigmentation as well as those blisters in the sun-exposed areas. Things that are black lesions are important to know about as well. Remember melanoma, we talked about having changes in color from one site to another. A lentigo, there are variations on a typical lentigo, which we think of as being tan or brown. There's one called an ink spot lentigo, which can be suspicious for melanoma, but instead is just dark brown and is not dangerous. Other things, anthrax is important to keep in mind. When you see a lesion with a black S-scar on the surface. Remember we talked about that Pseudomonas-induced ecthyma gangrenosum, which has necrosis associated with it, and that's also black in appearance. So here's your chance to vote. Which skin finding is most often associated with the autosomal recessive polyglandular deficiency syndrome? Okay, good. So most everybody was paying attention. The vitiligo, remember, goes along with that. Okay, just one word on pruritus. The most common cause is xerosis, so the first thing to look for is plain old dry skin when patients come in and are itchy. But there also can be systemic problems resulting in pruritus, and so often the workup for us in dermatology for patients with generalized pruritus includes a series of lab work, including thyroid disease, checking iron levels, checking for liver and kidney function, and also age-appropriate cancer screening, so looking for things like Hodgkin's disease or breast cancer. And last, we're going to talk about skin and systemic disease. So first up is diabetes, and about a third of patients with diabetes have cutaneous manifestations, and those kind of fit into one of several different categories. There are some general disease associations, and acanthosis nigricans is definitely one of those. So remember that velvety hyperpigmentation that we just talked about, especially in skin folds and on the back of the neck. Eruptive xanthomas are also seen in diabetes, and these are associated specifically with an acute elevation in their triglycerides. Once the triglycerides return to normal, these usually resolve. So these look like kind of pinkish or yellow papules that appear acutely. Here you can see on this patient's knees, which is a common location on the legs here. Sometimes can be on the buttocks, and we'll see an example of that as well. So again, keeping that typical appearance, kind of yellowish, like a xanthoma you would think of, but also a little bit pink color to them as well. Here over a flexure here as well, this may be patient's elbow. And then here again on the buttocks, so kind of pinkish, kind of yellowish, acute onset, high triglycerides. And here again. And still with the same shape, even though it's a different patient, that kind of yellowish round papules here. Other disease associations with diabetes include vascular changes. So necrobiosis lipoidica fits into this category, and we used to call it necrobiosis lipoidica diabeticorum because about 75% of patients who have this have diabetes, but not all of the patients, so it's not fair to add that on there. This typically looks like atrophic, yellowish orange, or sometimes tan colored patches that are classically located on patients' shins. So here you can see these large atrophic patches with that kind of tan orange coloration to them. Here this patient has a little bit more epidermal involvement with kind of some scaliness, but here I think you can appreciate kind of looking from the normal skin to the affected skin through here that this is atrophic, so this is sort of sunken down into the skin. And here's another, again with a little bit of scaliness on the surface, but still in the shin location, kind of hyperpigmentation, a little erythema, and maybe some of that kind of yellowish orange discoloration. And here's another patient with the positive biopsy sign, so this patient's been biopsied. Sometimes can ulcerate. So this could be a biopsy sign here, but more likely this is a patient who's developed an ulceration within their patch of necrobiosis lipoidica. But here down here you can see maintaining that kind of yellowish pink discoloration, and again kind of an atrophic patch here on the patient's shin. And then here's a patient with very severe and extensive ulceration as a result. This is definitely the exception. While it can ulcerate, usually does not, although again, trauma or something to sort of incite ulceration is more likely than just spontaneous. And here again, on the dorsum of this patient's feet, atrophic patches, kind of a yellow coloration, and kind of a yellowish orange discoloration here. Patients with diabetes are more susceptible to infections, and lots of infections that we've talked about already. Remember candidiasis that likes that macerated skin in the diaper area. Remember the peripheral pustules that go along with that. Remember our elderly patient with perlesh and involvement in candidiasis at the corners of the mouth, and then a patient with more extensive mucocutaneous candidiasis here involving the trunk. Remember to scrape this off, results in bleeding underneath there. Bacterial infections. So I know you all remember this patient from earlier because this patient has impetigo, right, with that honey-colored crust there. And then a patient with folliculitis here. All of these can be more common in patients with diabetes. Mucormycosis, not a lot in the way of cutaneous findings, but remember this is a fungus. A very large hyphae compared to, say, the dermatophyte that we were looking at. Here you can see in the background here, this is the mucormycosis organism, and here you can see, remember that's more common in poorly controlled diabetics affecting this patient's eye. And then there are neurocutaneous complications in diabetes. That basically is things that occur as a result of their peripheral neuropathy, like ulcers in the skin. Next up is HIV and AIDS. And there are a lot of different cutaneous manifestations here. These patients are more susceptible to infection, just like the diabetic patients as well. But xerosis is a common finding in acquired ichthyosis, which is what's going on in this picture. Remember we talked about ichthyosis vulgaris, which usually is present from birth and seen in atopic individuals, but this is acquired ichthyosis, or plate-like scale, and when a patient comes in with this, then HIV is definitely something you need to think about checking for. Seborrheic dermatitis can be very severe in HIV-infected patients. Remember, we talked about that when we were reviewing seborrheic dermatitis at the beginning. And remember, one of the patients we saw had severe seborrheic dermatitis that was not responsive to standard treatment. So an HIV test is important. And remember, it looks like these erythematous patches with the silvery scale on there. I mentioned that infection is more common. So this is a patient with HSV, and remember what it typically looks like, which were those vesicles on an erythematous base. But here, in a patient who's really not mounting much of an immune response, you can develop a large erosion like this, and also here around the mouth, as opposed to having that typical classical dewdrops on the rose petal appearance to it. Condyloma definitely can be more common in patients with HIV, remember, caused by HPV, and can be quite severe. Molluscum, and remember the classic appearance for molluscum was that flesh-colored or whitish umbilicated papule, but they can get very, very large in immunocompromised individuals. So this patient has a giant molluscum here with some ulceration that's present as well. And then remember, EBV in HIV results in oral hairy leukoplakia. So that's the hyperplasia of the filiform papilla on the lateral surfaces of the tongue that cannot be scraped away. And then finally, Kaposi sarcoma. So remember, this is a vascular proliferation attributed to HHV8. And here you can see on this patient's leg those vascular purplish tumors. Here again, another example of Kaposi sarcoma with these vascular tumors on the patient's leg, and the patient's even developed an ulceration here. Another can definitely be numerous, and these tend to resolve once patients' immune systems are reconstituted. So when patients present with this, which is less frequent now than it used to be before heart treatment, reconstituting the immune system can be very helpful in helping them to go away, and surgical excision is an option as well. Here's a patient with a Kaposi sarcoma involving the hard palate here. And you made it. So the end.